and also our patron Dr. Ramesh for coming all the way from Trichy to attend this meeting. So thank you, and because we are starting late, I thought we have to finish by 11. So I thought we have 2 lectures on arrhythmias. Actually, arrhythmias have got 4 lectures, namely premature beats, narrow QRS tachycardia, wide QRS tachycardia, and slow pulse. So because of the time limitation, we will be able to do only 2 lectures, like narrow QRS and wide QRS tachycardia, as the program is there. So I start with cardiac arrhythmias unraveled. So first of all, you must know what is unravel. Unravel is a mysterious, unknown and complicated subject is being made known, understood, and also becomes easy. That's what unravel is. These 3 words, mysterious, we can switch off this slide. If you look at these 3 words, mysterious, unknown and complicated subject, this exactly fits in with arrhythmias. Arrhythmias are mysterious, they are unknown, they are complicated. So what we are going to do is to make it known and make it understood and make it easy. So although we say that the arrhythmias is a very difficult topic, there is only one easiest thing in arrhythmia, that is its definition. The definition of arrhythmia is any rhythm other than normal sinus. So that is the easiest part in the arrhythmia is its definition. Any rhythm other than normal sinus rhythm is an arrhythmia. For that you must know what is normal sinus rhythm. Whenever we say normal sinus rhythm, we mean that the impulse to the sinus node is originating from the sinus node, and it is spreading along the normal conduction system at the right speed and the right pathway and reaching the appropriate place, and the appropriate place is responding to this current correctly. So that is what we mean by normal sinus rhythm. So the normal sinus rhythm has got 6 criteria. One is your P wave has to be upright in L1. Your P wave has to be inverted in AVR. There should be constant PP cycles, by which we mean that the interval between 2 successive P waves should be constant throughout the ECG. You must have a constant PR interval, and you have a constant RR interval, and the heart rate should be between 60 to 100 per minute. So the sinus rhythm should satisfy all the 6 criteria. If an rhythm is not satisfying even one of these criteria, it is called arrhythmia, arrhythmia. So if you look at the electrocardiogram, first of all you have to make sure that the P wave is upright in L1 and it is inverted in AVR. That's the first thing to say is sinus rhythm. Then you must see what is the interval between 2 successive P waves, and this interval should be constant throughout the ECG. Then you look at the PR interval, and this PR interval should be also constant throughout the ECG. Then you look at the interval between the 2 successive R waves, and this interval also should be constant throughout the ECG, and of course the heart rate should be between 60 and 100 per minute. So this is what the normal sinus rhythm. So any rhythm which is not satisfying this 6 criteria is called an arrhythmia. So once you decide arrhythmia, we divide the arrhythmia into bradycardia and tachycardia. The bradycardia, the heart rate is less than 60 per minute, and the tachycardia heart rate is more than 100 per minute. Both can be regular or irregular. So first of all, before we go into the arrhythmia diagnosis proper, what is your emergency room approach or the triage approach to any arrhythmia? Any arrhythmia, the importance is not the diagnosis, it is a patient. Please remember, the diagnosis of the ECG is not important. What is important is the patient. So whenever the patient comes with arrhythmia, what you have to see whether the patient is stable, by which we mean the patient has got a recordable BP, good pulse rate and warm extremities and is quite conscious and clear. So this means that the arrhythmia is not endangering the hemodynamics of the patient. So whenever the patient is stable, you may try to make a diagnosis from the ECG, give pharmacological treatment, and then try the electrical treatment. In a tachycardia, it may be a shock, or in a bradycardia, it may be a pacer. If the patient is unstable, his pulse is not felt, the BP is not felt, the patient clothed and clammy, is disoriented, which means this arrhythmia is producing significant vital organ hyperperfusion. So this is a hemodynamically unstable arrhythmia. Here you have to do electrical treatment first. Tachycardia is shock, and the bradycardia spacer, then make a diagnosis of the arrhythmia. For example, you are in ICU and the patient is suddenly developing an arrhythmia and is going for cardiac arrest. That means is no pulse, no blood pressure, and he loses consciousness. That means this arrhythmia is producing a cardiac arrest. So in this patient, you have to immediately start the resuscitation through the cardio-cerebral resuscitation followed by a current or cardioversion. So this is your first approach in any arrhythmia. So in any arrhythmia, don't see the ECG first. So you think the patient has got an arrhythmia, see the patient first and decide. If the patient is stable, diagnose and treat. If the patient is unstable, treat and diagnose. And the patient has got a cardiac arrest, start resuscitation. So this should be your first approach in any arrhythmia. Then of course we must know about the complex pathophysiology of arrhythmias. As I told you, it can be because of two important pathophysiological mechanisms which can produce arrhythmia. One is abnormal impulse generation, another is abnormal impulse conduction. So most often abnormal impulse generation produces tachycardia. Most often abnormal impulse conduction will produce bradycardia. So that is a gross rule. But the exceptions do happen. So whenever there is abnormal impulse generation, so it can be increased automaticity of a pacemaker, increased irritability of a pacemaker. So if it is a normal pacemaker itself has got increased automaticity, it is usually a sinus tachycardia. So enhanced automaticity of the normal pacemaker is sinus tachycardia. For example, if this ectopic focus is going to be other than sinus node, like atrium, junction or the ventricle, it becomes an automatic tachycardia. So any one of the focus from the atrium, junction or the ventricle will fire rapidly. So this is called automatic tachycardia. So ectopic focus can increase automaticity. So both will produce a tachyarrhythmia. So then we have very rarely called triggered rhythms can produce tachyarrhythmia. Triggered rhythms can be, for example, this is an action potential. A triggered rhythm can produce another action potential, either after the ending of the previous action potential or before ending the previous action potential. So this is called delayed after potential and this is called early after potential. So the mechanisms of delayed after potential is indicated in digoxin-induced arrhythmias, bilateral ventricular tachycardia, biventricular tachycardia, and also catecholamine ventricular tachycardia. In these three particular tachycardias, we have delayed after depolarization. Whereas whenever the patient got a long QT syndrome, the problem is the early after depolarization. So next depolarization is coming close to the depolarization or coming after the depolarization. Besides peculiar arrhythmias, there are some peculiar arrhythmias where the mechanism is different, pathology is different, and the treatment is also different. Then we come to the abnormal impulse conduction is most often bradyarrhythmia. Either the impulse is produced and it is not coming out of the junction. For example, sinus node produces the impulse, it is not coming out of sinoatrial junction, it is sinoatrial block. If the sinus node produces the impulse and the impulse has gone through the atrium and that atrial impulse is not reaching the ventricle, it is atrioventricular block. So it can be a sinoatrial block or atrioventricular block, which can be divided into first degree, second degree and third degree blocks, which can produce a bradycardia. Sometimes we can see the abnormal conduction can produce a re-entry. What we mean by re-entry is that whenever there is an abnormal tissue is there, for example, the impulse is going through an abnormal tissue, let us say a small infarct or a fibrotic myocardium, what the impulse will do is when it coming and coming into the contact of the abnormal tissue, there will be two pathways. One pathway is the other side of the abnormal tissue, other pathway is this side of the abnormal tissue. So usually what happens is this particular impulse will go through on either side of this abnormal tissue equally to reach and distal myocardium. So it will go equally to the both pathways and reach the distal myocardium. But very rarely what happens is when a premature beat happens, because the another important thing you have to understand, these two pathways will have a different refractory period. It's not the same refractory period, they will have a different refractory period. So when a premature beat happens, what will happen is it will block one pathway and allow the impulse to go through the pathway which has got a shorter refractory period, so that the impulse comes back and go through the previous blocked pathway to produce a rapid re-entry mechanism. So that will produce a tachycardia. So one exception where an abnormal impulse conduction is going to produce a tachycardia as a re-entry tachycardia, because it's a unilateral block of a particular pathway surrounding the abnormal tissue. So these are the mechanisms of arrhythmia: abnormal impulse generation and abnormal impulse formation. So these are the 4 lectures we used to do in our arrhythmias. So we are going to do only 2 lectures today. So I just give you an approach to an abnormal beat. So abnormal beat, whenever you come across an abnormal beat like this is your normal sinus rhythm, and the abnormal beat is here. So normal sinus beats are here. Suddenly you find an abnormal beat. So you must always see whether this abnormal beat is before the next expected sinus beat or it is coming after the next expected sinus beat. For example, you have 4 squares between these 2 beats, and you are supposed to get another sinus beat here. Here the another sinus beat is not coming. Because of that, there is an abnormal beat coming after the next expected sinus beat. As you know, we have primary pacemakers and secondary pacemakers. Primary pacemaker is sinus node. Secondary pacemaker is your junction and the ventricles. So whenever the primary pacemaker fails or the primary pacemaker impulse is not reaching the ventricle, secondary pacemaker will take over. So here what happens is the secondary pacemaker of a ventricle is taking over because the primary pacemaker is failed, so that the heart is not allowed to go for a asystole. So here it is called escape beat, which is coming from the secondary pacemaker. Why it is called escape beat? Most often your secondary pacemaker is under the influence of the primary pacemaker. Most often the secondary pacemaker do not manifest. But when the primary pacemaker is failing, the secondary pacemaker is manifesting. It is escaping from the influence of the primary pacemaker and it is manifesting. That's why it is called escape beat. So escape beat usually comes after the next expected sinus beat. Here what is your treatment? You should not be suppressing this beat. Because it's an abnormal beat, you should not be suppressing this beat. What you have to do is you have to make the sinus ripple to come here. When the primary pacemaker is working, the secondary pacemaker automatically will go for. So here the treatment of choice will be treat the pause and not the beat. So you have to treat the pause and not the beat for the escape beat. Whereas now you can see I have an abnormal beat which is coming before the next expected. So next expected beat is supposed to come here. But this abnormal beat is coming before the next expected sinus beat. So this beat is a premature beat. So premature beat is a beat which comes before the next expected sinus beat. Premature beat also will be followed by a pause which we call as a compensatory pause. So if you want to treat this pause, you have to eliminate this beat and not give a stimulant to treat this pause. So here what you have to do to eliminate that pause is treat the beat, not the pause. So this is a premature beat, you have to treat the beat and not the pause. So if you see the differences between escape beat and premature beats, escape beat comes after the next expected sinus beat. This comes before the next expected sinus beat. So basically it is a bradycardia which produces the escape beat. So it is not necessary to have a bradycardia to have a premature beat. So escape beat is a protective phenomenon and it saves the heart from asystole. Whereas a premature beat is an irritable character of the ventricle or the atrium or the junction. It can induce a tachycardia. So it is an irritable phenomenon and can produce a tachycardia. Escape beat should not be suppressed, whereas premature beat may be suppressed according to its malignancy. And that's what we told you. Escape beat, treat the pause and not the beat, whereas in a premature beat, treat the beat and not the pause. So this is your first approach to any abnormal beat. What you have to see is whether it is coming before the next expected sinus beat or it is coming before the next expected sinus beat, so that you know what exactly to do for that premature beat or an escape beat. So with this, I will go to my lecture on a narrow QRS tachycardia. So these premature beats can be atrial, ventricular or junctional. So you most often will give a lot of importance to ventricular premature beats because they are more common. So the ventricular premature beat will have their own characteristic to say whether that premature beat is going to be malignant or benign. So what we are going to do is navigating through the narrow QRS tachycardia. So now first of all we must define what is a tachycardia. Any rhythm where your atrial rate and or ventricular rate is more than 100, it is called tachycardia. Whenever the ventricular rate or the atrial rate more than 100 is called tachycardia. So, a tachycardia when you have the rate more than 100 per minute. So, what are the clinical presentation of a tachycardia? The patient may come to a palpitation. Patient may have a pulsation in the neck, especially some sort of junctional tachycardias. You can have a pulsation in the neck, and the people may say it's a butterfly in the chest. Sebastian, you can switch off the slides, just irritated. A patient may have a fatigability because of the decrease in cardiac output, and many times in a supraventricular tachycardia, there may be a patient may have a post-palpitation polyuria because of a decrease in antidiuretic hormone. So, then the most malignant symptoms of any arrhythmia or any tachycardia will be the three things. Whenever the patient has got chest pain, breathlessness and syncope, you have to give lot of importance to that particular tachycardia, because this tachycardia is endangering coronary circulation to produce chest pain. It is producing heart failure to produce breathlessness. It is endangering cerebral circulation to produce loss of consciousness. So these three are malignant symptoms in any tachycardia. So history itself will tell you whether this tachycardia is malignant or benign depending upon the symptoms. Then of course you classify the tachycardia into the QRS width. If the QRS width is less than 120 milliseconds, by which we mean 0.12 second, if the QRS is going to occupy less than 3 small squares, it is called narrow QRS tachycardia. If the QRS width is more than 120 milliseconds and it is going to occupy more than 3 small squares, it is called wide QRS complex tachycardia. So this is the basic definition. Once you decide tachycardia, look at the QRS duration. If it is less than 120 milliseconds or more than 120 milliseconds, then of course it can be regular or irregular. So once you decide tachycardia is more than 100 per minute, you can look at this tachycardia. You can look at the tachycardia width, and the width is actually more than 120 milliseconds wide QRS complex tachycardia. So if you look at the QRS here, the QRS width is actually less than 120 milliseconds. So it's a narrow QRS tachycardia. Whereas here you can see that the tachycardia rate is more than 100 per minute, but your QRS is more than 120 milliseconds. So this is a wide QRS complex tachycardia. So this is the first important classification. Tachycardia, narrow QRS, wide QRS. Then of course, whenever we see the narrow QRS tachycardia, usually call them as supraventricular tachycardia. Because it's understandable whenever your tachycardic impulse is starting above the ventricle, like sinus node or in the atrium or in the junction, it has to travel through the normal conduction system of the heart to depolarize the ventricle. Whenever the impulse comes through the normal conduction system, the normal specialist conduction system of the heart, like his bundle branches of physical conduct the impulse at the speed of 44 meters per second. So rapid conduction to the ventricle, so naturally your QRS is narrow. So whenever the impulse is arising above the ventricle, it is called supraventricular tachycardia. Most of the supraventricular tachycardias will have a narrow QRS complex tachycardia. But not all supraventricular tachycardias are narrow QRS. Please remember that. So you can have supraventricular tachycardia which can have wide QRS, which we see in the next chapter. Whereas all narrow QRS complex tachycardias are SVTs. So all narrow QRS complex tachycardias are SVTs, but not all SVTs will have a narrow QRS. So that is an important point you have to remember. So it can be a sustained or non-sustained. If the tachycardia is going to happen at a very brief time of less than 30 seconds, it is called non-sustained. It is going to happen continuously. It is called sustained. It can be paroxysmal. It comes and goes, or it may be a persistent. For years together, patient may have atrial fibrillation. So it's a persistent tachycardia. Then I told you whether it is a regular tachycardia or irregular tachycardia. What do you mean by regular tachycardia? Having decided it is a tachycardia, having decided it's a narrow QRS tachycardia, we have to see what is the interval between two successive R waves. Throughout the ECG, my interval between the two successive R waves is absolutely constant. It is a narrow QRS complex tachycardia, which is regular. Whereas you can see that here, my R interval is continuously varying. Sometimes it is short, sometimes it is long, sometimes it is normal. So continuous variation of R interval tells you It's an irregular narrow QRS complex tachycardia. So these are the mechanisms of all narrow QRS complex tachycardia. So the first and foremost is the sinus tachycardia. Sinus tachycardia is the most common cause of narrow QRS complex tachycardia, where I told you have an increased automaticity of the normal pacemaker. The sinus tachycardia, the sinus rhythm is producing more impulses, so you have a sinus tachycardia. Whereas one of your ectopic foci focus from the atrium is maybe firing rapidly. So one of your irritable focus in the atrium is firing rapidly. Subsequently, the impulse is going to go through the normal conduction system. So this is called ectopic atrial tachycardia, or some people call it paroxysmal atrial tachycardia, PAT or EAT. Then, of course, you can have 3 or more foci in your atrium firing rapidly. So it is not one focus. 3 or 4 foci in your atrium is firing rapidly. So that means it is multifocal atrial tachycardia or MAT. Then, of course, you can have what is known as atrial flutter, where you can have a macro re-entry circuit inside your atrium. So that is atrial flutter. Whereas whenever you have this re-entry circuit is happening in the right atrium, it is atrial flutter. If the re-entry circuit is happening within the AV node, it is called AV nodal re-entry tachycardia. If the re-entry circuit is going to have an accessory pathway as the arm of the re-entry circuit, it is called atrioventricular reciprocating tachycardia. Very rarely you can have a junctional focus which is irritable. It is not re-entry, just like your atrial focus was irritable. Junctional focus is irritable and firing rapidly. It is called junctional ectopic tachycardia. So junctional tachycardia can be AV nodal re-entry, which includes the re-entry within the AV node, or an accessory pathway mediated re-entry, or junction itself starts firing automatically, junctional ectopic tachycardia. Then very rarely we can have what is known as a permanent junctional re-entry tachycardia, where an accessory pathway is conducting retrogradely very slowly. So that is called Comel's tachycardia, very rare tachycardia of PGRT. So these are actually your mechanisms of all narrow QRS complex tachycardia: sinus tachycardia, ectopic atrial tachycardia, multifocal atrial tachycardia, atrial flutter, and these are the regular tachycardias, narrow QRS regular tachycardias: AVNRT, AVRT, junctional ectopic tachycardia, permanent junctional re-entry tachycardia. So these are the tachycardias. Whereas the mechanism of irregular tachycardia are 2. One, the multifocal atrial tachycardia is not going to be regular. It is an irregular narrow QRS tachycardia, some multifocal atrial tachycardia. Whereas when your atrium is going to fibrillate, and these fibrillary waves are going to be conducted through the AV node irregularly, you have an irregular narrow QRS tachycardia. This is atrial fibrillation. So these 2 tachycardias are likely to be irregular, whereas all the other tachycardias are likely to be regular. So we understood the regular tachycardias and irregular tachycardias and the mechanisms of each one of these tachycardias. So regular narrow QRS tachycardia, as we have said, it could be a sinus tachycardia. The AVNRT can be typical AVNRT or atypical AVNRT. And atrioventricular reciprocating tachycardia utilizing an accessory pathway, which can be orthodromic and antidromic. We will tell you something about that. And it can be a ectopic junctional tachycardia or junctional ectopic tachycardia. Then you can have atrial ectopic tachycardia, EAT or PAT. Atrial flutter with a constant conduction. Atrial flutter can come under narrow QRS regular or irregular, depending upon whether your AV node is conducting constantly or AV node is conducting irregularly. And of course, you have a very rare form of permanent junctional re-entry tachycardia. So how are we going to approach the narrow QRS complex tachycardia is going to look at not the QRS. We have decided that the narrow QRS tachycardia are regular. Then we are going to look at very carefully about the P wave. So in P wave, there are a number of things we have to see. Whether the P wave is coming after the QRS or it is no P wave at all in the tachycardia. If the P wave is coming, if it is coming after the QRS, what we know as RP dash. P dash means the P wave during the tachycardia. So this P wave, which is coming after the QRS, if it is coming after the QRS, it is coming very close to the QRS or within the QRS is one point, or it is coming a little late. The P wave is coming in the retrograde and it is ST segment is one point, or it is coming very late. That means RP interval is so long the P wave is coming before the next QRS. The P wave is coming not after this present QRS, it is coming before the next QRS. It's a very long RP dash tachycardia. So if you want to decide the narrow QRS tachycardia, it can be no P wave at all, or a very short RP interval, or little long RP interval, or very long RP interval. So this is how we understand this tachycardia. What do we mean by that? For example, if I have the QRS, I have to carefully see whether I have a retrograde P wave in the ST segment or within the QRS. So for example, if I have this retrograde, what we mean by retrograde P wave? It has to be inverted in L to LT wave, because the P wave is going from below upwards to depolarized state, because it's a junction. The origination of tachycardia is in the junction, so or in the atrium. If it is going to be going from below upwards, the P wave will be inverted in inferior leads. So whenever the P wave is inverted, from the junction, the P wave is going up. So whenever this retrograde P wave is in the ST segment, it is a short RP interval tachycardia. Whereas this is what I do. When your P wave is very long, this P wave, the distance between the QRS and the next P wave is very long, and it is going to come before the next QRS. It is a very long RP interval. So whether the RP interval is present or not, some tachycardias will not have the P wave at all. But some tachycardias will have the P wave after the QRS. Some QRS, some tachycardias will have this P wave before the next QRS. So short RP tachycardias and long RP tachycardias. So what are they? Whenever you look at the RP dash interval, if it is nothing, you don't have a retrograde P wave at all. Only QRS, no P wave. Not after this QRS or not after the next QRS. It is most often atrioventricular reentrant tachycardia. Atrioventricular reentrant tachycardia. If you have a short RVR, that means you have a retrograde P wave in the ST segment. Retrograde P wave comes just after the QRS, and P wave is inverted in inferior leads. It can be atrioventricular retrograde tachycardia. This is the important differentiation between the commonest junction narrow QRS tachycardia like AVNRT and AVRT. Then whenever you have a P wave coming before the next QRS, where there is a very long distance between your QRS and the next P wave, it can be a sinus tachycardia, ectopic tachycardia, atrial flutter, atypical form of AVNRT, or I told you, very rare form of permanent junction reentrant tachycardia. So these are the long RP dash tachycardias. So in this particular very long RP dash tachycardia, what is important? The P wave is going to come before the next QRS. So these are the types where, so whenever the P wave is coming before the next QRS, you have to think of these tachycardias. Whenever your retrograde P wave is just coming or not there or coming immediately to the present QRS, you have to think of AVNRT and AVRT. So this is a simple approach. So in the AVNRT, there is a AV node reentry is happening within the AV node, and there is a simultaneous antigrade depolarization ventricle and simultaneous retrograde degradation of atrium. So you don't have the retrograde P wave which is coming after the ST segment. So this retrograde P wave is inside the QRS or very short, maybe at the end of the QRS. And you don't have a more RP dash interval here, because there is a simultaneous depolarization of atrium and ventricle. So whenever you don't have the RP interval at all, the diagnose AVNRT. Whereas what happens in atrioventricular reentrant tachycardia is you have the retrograde P wave in the ST segment. You have a distortion of the ST segment, and present QRS will be followed by the retrograde P wave, which is inverted in L2 L3 AV of short RP dash interval. So the P waves are going to be inverted in this retrograde P wave, because what? Junctional reentry is happening, antigradely ventricle is depolarized, retrogradely your atrium is depolarized, because this P wave is going away from inferior leads. The P waves are inverted in inferior leads. We look at the mechanism. The commonest cause of the narrow QRS tachycardia occurring in a normal heart, structurally normal heart, commonest cause of narrow QRS tachycardia is AVNRT, AV node reentry tachycardia. As I told you, the reentry circuit is happening within the AV node. The reentry circuit is happening with the AV node. The heart rate may be 150 to 250. Most common type of SVT in adults and more common in women, and also most often these people will have structurally normal heart. Structurally normal heart. So now I am going to tell you the AVNRT mechanism so that you will understand. So what happens is, what is the re-entry? I have an abnormal tissue here, and the impulse is going to go through both the arms around the abnormal tissue and go to the distal myocardium to depolarize the myocardium. So usually in this AV node, in people who are destined to have an AVNRT, these two pathways are divided into slow pathway and a fast pathway. The slow pathway is going to conduct the impulse slowly, but it will have a shorter refractory period. So opposite, it is going to conduct slowly, but a shorter refractory period. Whereas a fast pathway is going to conduct the impulse very fast, but has got a longer refractory period. So slower, but longer. Slower and shorter. You can remember 2 S. Slower and shorter. So then what happens is, what actually precipitates an AVNRT is a premature beat. So normally what happens, both the impulses are going through both the arms and they will be depolarizing the distal ventricle. But what happens in a AVNRT, usually an atrial premature beat precipitates AVNRT. So what this when the premature beat comes early, because of the two different refractory period, one pathway would have recovered, one pathway would not have recovered. Which pathway would have recovered? The slow pathway, which has got a shorter refractory period, would have recovered, isn't it? So naturally what this impulse will do, it will go through the slow pathway because it has got a shorter pathway. Because it is going slowly, by the time it reaches the end point of this abnormal tissue, this pathway would have recovered. This fast pathway, which has got a longer refractory period, would have recovered now. So what the impulse will do, it will go back to the faster pathway and start producing a rapid re-entry circuit, and this rapid re-entry circuit will be conducted to the ventricle to have a faster ventricular rate. So this is the mechanism of a typical AVNRT, where it is called slow fast pathway. That is, antegrade conduction is slow pathway, retrograde conduction. So you can see that here, the fast pathway. So this impulse is going through the retrograde to the fast pathway to establish a rapid re-entry circuit, and this rapid re-entry circuit will go through the ventricle to have a rapid ventricular rate. So this is how the typical AVNRT is produced. Now what is the importance? For example, it is called the slow fast pathway. Why it is called slow fast? Antegrade conduction is called the slow pathway, retrograde conduction is called the fast pathway. So this is a typical AVNRT. Here what is happening is, the retrograde conduction is through the fast pathway. So that means what? The fast pathway will retrogradely depolarize the atrium very fast. So it will simultaneously will happen along with antegrade depolarization of the ventricle. So you have a fast atrial depolarization. So that means what? Your retrograde PY may not be seen at all, because there is a simultaneous happening of the retrograde atrial activation and antegrade ventricular activation. So that's why in a AVNRT you don't see a P wave. Or if you may see, maybe at the end of the QRS a blip, not in the ST segment. So that is the importance to differentiate. So you can see the tachycardia here. What is the first approach? It is a tachycardia, heart rate is more than 100. Then the QRS is narrow. So it's a narrow QRS tachycardia. Then like you look at RR interval, it is constant. So it is a narrow QRS regular tachycardia. Then I have to see whether I have what the P wave is about. I don't have a P wave in front of next QRS. So this is not long RP dash tachycardia. Then I carefully look at the P wave in the ST segment. The ST segment also I don't have the distortion. But at the end of the QRS, I have a very small blip. You can see that here. I have a very small blip there. That is your retrograde atrial activation. Sometimes it may be seen, but not be seen. So whenever you don't see a P wave in front of the QRS and after the QRS, it is likely to be AVNRT. And why it is AVNRT typical? Antegrade conduction is through the slow pathway. Retrograde conduction is going to go through the fast pathway. So this is a typical AVNRT. So slow fast pathway tachycardia. So you can see that the blip, small blip I have shown you in V1, there is called a pseudo R wave in V1. So usually AVNRT will have a pseudo R wave in V1 because of the retrograde P wave which just mimic a R wave in V1. Now what happens in atrioventricular rescue tachycardia is, my accessory pathway is away from my actual re-entry mechanism. So this is called antidromic tachycardia. Antidromic tachycardia will produce narrow QRS complex tachycardia. What we mean by antidromic? My antegrade conduction is through the normal pathway and the retrograde conduction is through the accessory pathway. Because antegrade conduction is through the normal pathway, my re-entry tachycardia will have the narrow QRS tongue plus tachycardia because it is going through the normal conduction system of the tachycardia. So here what happens is the re-entry circuit has to go and travel to find the accessory pathway to go back to the atrium and depolarize. What will happen now? My retrograde atrial activation is delayed because it has to find the retrograde pathway to go. So what will happen to my retrograde P wave? It will be prolonged. It will come in a ST segment. So that tells me that it is not a simultaneous retrograde and antegrade activation of atrium and ventricle. My retrograde activation is little bit delayed. That means I have an accessory pathway. So during the tachycardia itself, you can predict this patient is going to have a pre-excitation syndrome and this patient may not have a pre-excitation syndrome. Thereby, you can remember and mechanism. Now you can see, once again, apply the same rules. Tachycardia, narrow QRS, constant R interval. So regular narrow QRS and tachycardia. Is there a P wave in front of my QRS? Nothing. So it is not long RP dash. Then what I have to see, whether I have a distortion in my ST segment. You can beautifully see my ST segment is distorted. Compare the previous ST segment. See that ST segment here. See that ST segment here. Completely clear ST segment. Can you see that here? So completely free ST segment. Whereas look at this tachycardia. You have the retrograde P wave happening in the ST segment. What does it mean? My retrograde P wave takes a long time to reach my ventricle. So I have to have an accessory pathway to have this tachycardia. So this is atrioventricular reciprocating tachycardia utilizing an accessory pathway. So that's why you have a retrograde P wave in the ST segment. So this patient, once you revert, will have a typical WPW syndrome pattern where you have the short PR interval and the initial delta wave. So you can see, although the patient does not have a previous ECG, during the tachycardia itself will say, when he gets reverted, he will have short PR and delta wave. Thereby, you will be impressing your colleagues, isn't it? So during the tachycardia itself, say what will be his resting ECG after the conversion. If it is AV and not, it is going to be normal. If the retrograde P wave is there, the patient is going to have WPW syndrome. So that's what. So this is the mechanism I told you. In a typical AV and RT, the slow pathway is antegrade, the fast pathway is retrograde. Because the antegrade activation and the retrograde activation occurring simultaneously, I have a retrograde P wave within the QRS or just immediately after the QRS. So this is AV and RT. Whereas in accessory pathway immediate tachycardias, the retrograde activation has to go through the accessory pathway to make the retrograde P wave. So this retrograde P wave come in the ST segment, which is inverted in L2, L3 AVF. Then it has to be AV-RT or atrioventricular reciprocating tachycardia. A very interesting clinical sign of AV and RT is regularly occurring Cannon waves. Why there is a regularly occurring Cannon waves? What is a Cannon wave? Cannon wave is the right atrium contracting against closed tricuspid valve. So all your atrial pressures are transmitted to the veins. So that is a Cannon wave. Because all this for AV and RT, your atrium and ventricles are contracting simultaneously because the activation is almost same. Because of that, all atrial contractions are happening on the closed tricuspid valve. So when there is a regularly Cannon occurring wave, it's called frog sign. So whenever the patient got a tachycardia and has got a frog sign, you need not even take an ECG. Without ECG itself, we can say this patient has got a tachycardia, he has got a narrow QRS complex tachycardia, and that narrow QRS tachycardia is AV and RT. Right? A simple clinical rule to say AV and RT. Then we come to this short QRS. So how to remember when there is a short RP? If it's a very, very short or no RP, it is AV and RT. It is short. The ST is have the retrograde P wave, it is AV RT. Then what are the differences between AV and RT and AV RT? That means it is most often in elderly, it is in the young, it is women in both. Neck pulsation will be seen in AV and RT, not in AV RT, because the retrograde P wave is little later. So that will tell you the mechanism. Terminal R wave or pseudo R wave in V1, RP interval is short, retrograde P wave in the ST segment. Basic ECG is normal here. Basic ECG will show WPW syndrome here. Then very rarely we can have what is known as a junctional ectopic tachycardia. It will exactly mimic your AV and RT, AV RT, because you have a retrograde P wave in the ST segment. So junctional ectopic tachycardia is a very rare tachycardia. It is an automatic firing of the junctional ectopic focus. It's not a re-entry mechanism. So very rarely it will happen in a post-operative cardiac situation very difficult to differentiate ECG-wise whether it is ectopic. The only clue is this tachycardia may not respond to your adenosine, because the adenosine, verapamil, diltiazem, beta blockers will make re-entry tachycardias to a normal sinus rhythm, not an ectopic tachycardia. So that is the difference between reflex tachycardia, re-entry tachycardias and automatic tachycardias. Re-entry tachycardia is very easy to get sinus rhythm because you are breaking the re-entry circuit. Here, one focus is firing rapidly that you may not be able to silence. So that's why when it is not responding, especially in a post-operative situation, it could be functional ectopic tachycardia. So these are the differences. Hemodynamic instability, it is a shock, and of course stable carotid sinus massage, IV adenosine, if it's effective, IV verapamil and diltiazem, IV beta blocker. If ineffective, we can give amiodarone. So you have a long-term treatment are available, beautiful treatment, permanent treatment for re-entry tachycardias, because you have to just block one re-entry. So re-entry tachycardias are happening because of the unidirectional block. The treatment is to produce bidirectional block. That's all. Treatment is to produce bidirectional. When you put a bidirectional block, re-entry cannot happen at all. Right? That's what they do in RF ablation. They make a slow pathway modification. What they do, they block also the slow pathway so that the re-entry circuit is not happening. Now we come to the next part. That means I have a very long RP dash tachycardia. That means my P wave is going to come before the next QRS. What are they? Sinus tachycardia, ectopic atrial tachycardia, atrial flutter, atypical AVNRT, and of course the permanent. These two are very rare, atypical AVNRT, and they are also not amenable to treatment, PGRT, and both are very, very refractory tachycardias. So whenever I have tachycardia, now what is important? Follow the same rules. Narrow QRS, tachycardia, regular, I see the P wave. I see a P wave in front of my QRS. So that means I have a very long RP dash tachycardia. See what is the P wave? P wave is upright in L1 and it is inverted in AVR. I have a biphasic P wave in V1. This P wave looks like sinus. Its configuration, height, tall, width, everything is sinus. Configuration is less than 2.5 millimeter in height. Width is less than 2.5 millimeter. I have an upright P wave in L1, inverted P wave in AVR. I have a biphasic P wave in B1. So this P wave satisfies all the criteria for the sinus P wave. So whenever a P wave is preceding the QRS and it is a sinus P, it is a sinus tachycardia. Right? So that's what you have to see what is the P wave is about. So one of the important and commonest cause of long RP dash tachycardia is a sinus tachycardia. We have to make sure that I told you that's why the important components of the sinus rhythm. So here the sinus route is firing rapidly. It is an enhanced automaticity of the normal pacemaker. So although we have different mechanisms of sinus tachycardia, what is very important is the most difficult arrhythmia in the world is sinus tachycardia. Not ventricular tachycardia, not ventricular fibrillation. I am afraid of sinus tachycardia because sinus tachycardia is always secondary to something else. The treatment is not giving verapamil or a beta blocker to sinus tachycardia. Treat the cause. It may be hypoxia, it may be hypotension, it can be an anemia, it can be a shock, and the tachycardia may be compensatory. Don't ever depress your compensatory mechanism of sinus tachycardia. So any sinus tachycardia, that's why the finding the cause is the most difficult thing. So all the arrhythmias, I know, AVNRT, adenosine, ventricular tachycardia, lignocaine, amiodarone. I have no tachycardia, I give a drug. But sinus tachycardia, I must know the mechanism. So that's why treat the cause and not the arrhythmia and sinus tachycardia. So then we come to the automatic tachycardias. For example, in any one of my atrial focus is firing rapidly, it is a atrial tachycardia, ectopic atrial tachycardia or paroxysmal atrial tachycardia. Newer term is called ectopic atrial tachycardia. So then what happens is you can understand here, my ectopic atrial focus is firing rapidly, it will depolarize the atrium and then will travel through the normal conduction system to the ventricle. That means what? I have a P wave in front of my tachycardic QRS complex, isn't it? Because the ectopic atrial focus has to depolarize the atrium, then only travel to the ventricles. But the problem is, because this ectopic atrial tachycardia will depolarize the atrium in a different direction, it will be different from the sinus P. The P wave will be there in front, But the P wave will not be looking like sinus. It will be bizarre, wide, it will be inverted. So whenever you have abnormal P wave, which is preceding the QRS, in a long RP dash tachycardia, it is likely to be ectopic atrial tachycardia. So now look at this tachycardia. So I have a tachycardia, all the things, narrow QRS, regular, everything, but I have a P wave in front of my QRS with no stretch of imagination. This could be sinus. You have a broad, big, downsloped P wave in front of the QRS. Now you know it is a tachycardia, all right, but this P wave is not coming from sinus. So it is coming from the ectopic focus other than the sinus node. So this is ectopic atrial tachycardia. What is the difference between the previous tachycardias? These are all called automatic tachycardias. Automatic tachycardias usually happens in a structurally abnormal heart. And they are less amenable to a treatment like adenosine and diltiazem or verapamil because there is no re-entry circuit. It is a single focus firing rapidly. So it is very difficult to get sinus rhythm. But what you can do is you can limit the ventricular response by blocking the AV node or AV node refractory increasing drugs. You can control ventricular response. Most often we may not get the sinus rhythm in automatic tachycardias. Whereas re-entry tachycardias occur structurally normal hearts. Very good response to your drugs like adenosine. What is the long-term treatment? Your re-entry mechanism can be ablated for a lifelong treatment or lifelong cure. Whereas ectopic atrial tachycardias, automatic tachycardias, your EP studies and RF ablation may not be so successful. So that's why, if at all God gives me that you must have a tachycardia, so no chance, you must have a tachycardia. So I'll always prefer to have a AVN RT or a AV RT. So where immediately I can get treatment and also I have a long-term cure. And not sinus tachycardia and not ectopic atrial tachycardia. So that's what. So that's what this thing is. Then we have the atrial flutter. In atrial flutter, you have a macro re-entry circuit usually happening within the AV node. Within the right atrium. So it is a macro, and usually in a typical AVNRT, it is a counterclockwise rotation. In a typical AVNRT, atrial flutter, it is a counterclockwise re-entry. Because it is counterclockwise, your retrograde flutter waves are going away from inferior leads. So in a typical flutter, the flutter waves are inverted in inferior leads. That's called typical flutter because the antegrade activation is going away from inferior leads in a typical flutter. So that's why the flutter waves can be irregular. So flutter waves are nothing, flutter tachycardia is nothing, extreme form of atrial tachycardia. So tachycardia, it is around 140, 160 you saw. Whereas I have a atrial rate of 300. What will happen? I will not have the time for an interval between two successive P waves. The P waves will coming one after the other rapidly. But P waves will be there, well-formed P waves will be there. But one after the other, they will come rapidly without intervening baseline. The two P waves will not have any baseline in between. So that will form a very typical pattern called the flutter waves, which is called the picket-fence appearance or a sawtooth appearance. So very typical flutter. So once again a flutter, if it is a constant conduction, you can see every third P wave is conducted. Throughout the ECG, every third P wave is conducted. It becomes under regular narrow QRS complex tachycardia. So now we can see the flutter sawtooth appearance in front of the QRS. So your flutter wave is in front of the QRS. So you have a P wave in the front of the QRS, but you have a flutter wave. So this is atrial flutter with a constant conduction, which can have a sawtooth appearance. Then, of course, you can have, sometimes what will happen is this flutter, when it is a 2:1 ventricular response, you will have a P wave in between the two QRS complex, exactly in the middle. You will think it is a sinus tachycardia with a prolonged PR interval. So, but the problem is, whenever you have a P wave between two RR interval in the middle, exactly in the middle, suspect atrial flutter, because you may have another P wave within the QRS which you will miss. So here it is called Biggs rule, Biggs rule, B-I-G rule. Whenever the P wave is in the exactly in between the two QRS complex, it can be a flutter which is mimicking a sinus tachycardia. If you do the carotid sinus massage here, so what will happen is, do the carotid, so you can see that here, it looks like a sinus tachycardia, but the flutter P wave is here. When you do a sinus tachycardia, you will increase the AV node refractory period and will beautifully demonstrate the flutter waves. So that is an important differentiation. So the atypical AV NRT, I'll just tell, but it is not going to be your common tachycardia. So in atypical AV NRT, so what will happen is that in a typical AV NRT, your retrograde conduction was through the slow pathway, retrograde conduction was through the fast pathway, and antigrade conduction was slow pathway, retrograde conduction was through the fast pathway, whereas in a atypical AV NRT, antigrade conduction is through the fast pathway, retrograde conduction is through the slow pathway. So because the retrograde conduction is slow pathway, what will happen to the P wave? It will take a very long time to reach the atrium and then regrade. So you have a very long RP dash tachycardia. So next P wave will be coming before the next QRS, but that P wave will be inverted. So that's what the atypical AV NRT is about. Very, very rare. Once again, you can see that there is a P wave in front of the next QRS. So it is a long RP dash tachycardia. But this P wave is retrograde or inverted because this is the retrograde conduction is through the slow pathway. So it takes a very long time. So whenever there is a long pathway, it can be. And very rare form of the tachycardia is permanent junctional tachycardia, where I have an accessory pathway which is conducting retrogradely very, very slowly. Retrogradely, very, very normal accessory pathway you have seen, AVRT, conduct little slowly, but the P wave is coming in the ST segment. Let us imagine this accessory pathway is conducting very, very slowly. The next P wave will come before the next QRS. So it's called Comel's tachycardia. These two tachycardias are very, very rare. Once again, you can see that inverted P wave coming before the next QRS. So whenever you have an inverted P wave coming before the next QRS, it can be either atypical AV NRT or permanent junctional re-entry tachycardia, which are very rare. If you don't remember, that's all right. So P wave just in front of the next QRS, that is a long RP dash tachycardia. What are the mechanisms? What are the differential diagnosis? When it is a normal sinus P wave, what is it? Sinus tachycardia. I have a P wave in front of the QRS, abnormal P wave, ectopic tachycardia. I have a flutter wave coming before the next QRS complex, it is flutter. Then of course, P wave inverted in inferior leads, it can be a low ectopic atrial. For example, I have a atrial tachycardia happening in the lower part of the atrium. Then what will happen? The retrograde P wave will go away from the inferior leads. These three things are very, very uncommon. So please remember at least these three important things whenever you have a long RP dash tachycardia. So summary of regular tachycardia, you have finished the regular tachycardias. So what I have to see the P wave, not the QRS. Where is my P wave and what is it? That will decide my mechanism of narrow QRS. P wave is retrograde. What does it mean? I have a P wave which is inverted in inferior leads and I don't have that P wave at all or just after the QRS, it is AVNRT. If I have the retrograde P wave in the ST segment, it is AVRT. And I have a very long RP. I have a retrograde P wave in front of the next QRS. It is either atypical AVNRT or permanent junctional atrial tachycardia or low ectopic atrial tachycardia. Whereas I have a P wave upright in inferior leads and it is coming before next QRS. It is sinus tachycardia commonest, isn't it? Sinus tachycardia commonest, and rarely you can have a tachycardia, atrial tachycardia also can have a P wave which is coming in front, but the configuration of the P wave will be completely different from the sinus tachycardia. So this is your approach to regular narrow QRS complex tachycardia. Then we come to the irregular narrow QRS complex tachycardia. So whenever the regular, so now what is the importance between the regular and irregular? The RR interval is constant in regular tachycardia. The RR interval is not constant in irregular narrow QRS complex tachycardia. So that is what the narrow QRS. So now we look at the irregular narrow QRS tachycardia. Once again, we have to look at the P wave. So what decides whether it's rare or regular is the P wave. Now the P wave is absent or present. In an irregular narrow QRS tachycardia, what is important? P wave is present or absent. So for example, here I have a P wave, but I have an irregular RR interval. You can see the RR interval is irregular, but I have a well-formed P wave, but the P wave is flutter. Flutter configuration of the P wave. That means what? It is atrial flutter with a varying conduction. My AV node is conducting irregularly the flutter waves. So atrial flutter will come under regular, as well as irregular. Now, I have a tachycardia where I told you multiple atrial foci are firing, multifocal atrial tachycardia. So this this is firing rapidly, this firing. So I have a tachycardia because these multiple areas are, multiple tachycardias are happening in a multiple foci of my atrium is actually firing. I have irregular tachycardia because this is not a regular one single focus firing. Multiple foci are firing. So they will have a irregularly coming to the AV node, and irregularly the AV node will be conducting. And because they are coming from the multiple foci, each P wave will have a different configuration, isn't it? Because this focus will depolarize atrium in a different way, this will activate different way, and this will act different way. So multifocal tachycardia by definition is first irregular tachycardia, second narrow QRS, and I must demonstrate 3 different types of P waves. 3 different type of P wave. For example, you can see I have a P wave here, which may be, you can see a P wave here, and I will tell you in a subsequent ECG. So you must demonstrate at D different P waves, and then only it becomes a multifocal atrial tachycardia. It's a rapid, irregular atrial rhythm arising from multiple ectopic focus within the atrium. Now you can see I have a tachycardia, narrow QRS, irregular, isn't it? That is the first step. Then I have to see whether I have a P wave or not. Yes, I have a P wave. Is it atrial flutter? No, because there is no typical atrial flutter. Then I see very carefully, look at one P wave here, which is different. Look at the other P wave, which is different. Look at the other P wave, which is different. So you can see at least 3 different type of P waves in multifocal atrial tachycardia. So it is not the same. It is the P waves are got, that tells you what? Multiple focus in the atria are firing rapidly, and they are coming from multiple directions. So the atrial depolarization is different formats. So the P wave will be different. So whenever you have 3 different type of P waves, and P wave is formed and it is irregular tachycardia, it is likely to be multifocal atrial tachycardia. And multifocal atrial tachycardia most often happens in non-cardiac condition. Most common cause is COPD, not only COPD, and the treatment of COPD, theophylline. The COPD and theophylline are the most common cause of multifocal atrial tachycardia, hypoxia, hyperpnea, respiratory acidosis, hypokalemia, hypomagnesemia. So the one arrhythmia which happens most commonly in non-cardiac conditions is multifocal atrial tachycardia. Then, of course, the commonest irregular narrow QRS tachycardia is atrial fibrillation. The 3 criteria to diagnose atrial fibrillation is absent P wave, no P wave at all here, and RR interval is irregular. The P waves are replaced by what is known as a fibrillary waves. The whole atrium is fibrillating like this. So there is no well-formed coordinated P wave. So these are the 3 criteria to diagnose atrial fibrillation, and the fibrillation can be coarse or fine depending upon the height of the P wave. If the P wave is less than, if the fibrillary wave is less than 1 millimeter, it is called fine, and the fibrillary wave is more than 1 millimeter, it is called coarse. So the fine atrial fibrillation and coarse atrial fibrillation. So what are the criteria? First, I find irregular narrow QRS complex tachycardia. Then I carefully see, is there a well-formed P wave? There is no flutter wave. There is no multifocal atrial P wave. I have a small undulating baseline. What is this undulating baseline? That is a fibrillary wave. And these are the 3 criteria to diagnose atrial fibrillation: narrow QRS irregular tachycardia, absent P wave, and fibrillary waves. So once again, the fine AF will have a bad prognosis when compared to the coarse AF. Whenever there is a fine AF, it tells you atrial myopathy. Many of your non-valvular atrial fibrillation will have a fine AF. Whereas your valvular atrial fibrillation like mitral stenosis, where there is a dilated atrium, you will have a coarse AF. There you have a definite method of treatment of tackling the valvular heart disease, whereas here it is basically atrial myopathy. So once again, you look at here a coarse atrial fibrillation, looks like atrial flutter. It will mimic an atrial, some people will call it a pseudo atrial flutter. But the flutters will be usually seen in inferior leads than the V1. But the flutter waves like atrial waves, but the V waves are not same. So this is a coarse atrial fibrillation. Most often happen in young people in mitral stenosis. The prognosis is good because you can correct the basic cause. So that's about atrial fibrillation. Then of course the rate of atrial fibrillation is very important. So if the rate is less than 60, it is a slow ventricular response. More than 100, or the next QRS. Then the duration, whether the P wave is normal or abnormal, whether sinus P wave or non-sinus P wave. And of course, configuration of P wave and whether the P wave is absent, atrial fibrillation. Thank you for your patient listening. So what we are going to do now is to go to the voting pads. So I tell you just how to use the voting pads. So many of your questions will have 2 or 3 or 4 right answers. We will be projecting an ECG or a question. So what you have to do will be to actually press the right answer. You can press the right number. Actually, majority of the time it's the right number. You will have a time. The time course will be around 15 seconds. So within the 15 seconds, you have to press the right number. If you have pressed the wrong number and your neighbor is pressing the right number, you can press it again. Within that 15 seconds, you can press any number of times. But the last number you have pressed will be your right answer. So in this way, we can see, everybody can respond, and you can also learn from your mistakes. So if you don't know the answer, press your lucky number today. So at least respond, right? So the first question is about, we'll skip that. I'll skip this. Which of the following is not sinusoidal criteria? Varying PR interval, constant PP cycle, constant RR interval rate between 60 to 100 per minute. What is the wrong option here? Start. The green bars will be the right answers. Excellent. Almost more than 80% of you are right. So the sinusoidal will have a constant PR interval, not varying PR interval. So that is the right answer. Then we are showing a tachycardia here. Put it in the big screen. You have a tachycardia here. So what is your approach? Tachycardia, narrow QRS, regular. Then what you have to see? You have to see the P wave in front. So if you have a P wave in front, see whether it's a sinus P wave. You can look at P wave in L1. You can look at the P wave in AVR. Look at the P wave biphasic in V1. So it is a long RP dash tachycardia. So it's a long RP dash tachycardia. So when you have long RP dash tachycardia, look at the P wave, whether P wave is sinus or not. In this ECG, that P wave is sinus or not. Tell me the answer. Start. Excellent. It is a sinus tachycardia, but this 3%, I am disappointed. VT cannot be a narrow QRS complex tachycardia. There I wanted 0% response. Whether you give right response or not, the VT I wanted a 0% response, isn't it? So this is a sinus tachycardia. Why? It is a long RP, all right. The P wave which is preceding the QRS is sinus. So this is a sinus tachycardia, right. So which is not narrow QRS complex tachycardia? I already told the answer, but I am asking you again. Start. At least for this, you give me 100% right. Excellent. Not 100%? 100%. Give you a good hand. Yes. Right. Commonest arrhythmia in normal hearts. Commonest arrhythmia in normal hearts, which is a re-entry tachycardia here. Start. Good. So AVNRT is a re-entry tachycardia. Most often these two are automatic tachycardias, which happens in a structurally abnormal heart. So I am showing you a tachycardia again. So look at narrow QRS complex tachycardia. Look at it is a narrow QRS complex tachycardia, and you see whether I have a P wave in front, whether I have a P wave at the back. Is there a P wave in front? You can see at V5, V6 here. Look at V5, V6. So is there a P wave in front or P wave at the back? Or if it is not there, and what should be the tachycardia?
So carefully see, I have a P wave, whether I have a P wave in front, or I have a P wave, any distortion in the segment, or I have a P wave in front. So what is this tachycardia? Start. Excellent. So you are experts in tachycardia. So I have an narrow course tachycardia. I have no P wave in front, no P wave at the back. That means I have a simultaneous antigradient activation. It has to be a AV node within the re-entry. Within the re-entry is within the AV node. So it is AV nodal re-entry tachycardia. Right. Now look at this tachycardia. So look at the tachycardia and carefully see the ST segment. Carefully see the ST segment. Now you have decide what tachycardia is. Same options. So decide what tachycardia is this. So you don't have the P wave in front, but you think there is a P wave at the back. So what tachycardia is? Start. Excellent. So you are all experts now. So when you revert this ECG, what will be the ECG? WPW. So tachycardia itself we can say and impress your colleagues. When you revert, the WPW will be there. So people will be amazed by your knowledge and you will get impressed by others. So you can see that retrograde P wave beautifully in the ST segment. That means your retrograde activation takes a little more time, but means it is going to utilize an accessory pathway. That's why it is AVRT. Right. So this is approach, very simple approach. Narrow course analysis, look at the P wave. There is no P wave at all. It is AVNRT. If the retrograde P wave in the ST segment, it is AVRT. Right. But if there is upright P wave before the QRS, see whether sinus, non-sinus, flutter or multiple. So that decides what tachycardia will be. Verapamil adenosine will restore sinus rhythm in what tachycardia? Re-entry or automatic? Start. Excellent. So re-entry tachycardias will be easier for the node to produce a block and then convert that into bilateral block and convert. Whereas one focus is firing rapidly, it is very difficult for these drugs or the EP mechanism to stop. Now you can look at this tachycardia. You can look at the inferior leads. You can see that classical pattern, isn't it? You can see that classical pattern. You can see that classical pattern. My statement is this is atrial fibrillation. Your answer is yes or no. Start. Excellent. So this is whenever there is a well-formed P wave, it is not atrial fibrillation. A simple rule. Whenever you have a well-formed P wave, it is a flutter wave. It's a classical flutter. Flutter, once you see a flutter, you will not miss the flutter in your life. So beautifully the sawtooth appearance of the flutter. Right. Now I have a tachycardia here and it is irregular. You can see the RR interval is completely irregular. I have one P wave here, another P wave here, another P wave here, another P wave here. My RR interval is irregular, preceded by a P wave, but the P waves are, I will not tell. Start. This excellent. So this is a multifocal atrial tachycardia. Irregular tachycardia, well-formed P wave, but the P waves at least 3 or more configurations. Multifocal tachycardia, most common cause is COPD and theophylline. So this is atrial fibrillation. Look at the RR interval. Look at the absent, whether there is a P wave is absent or present. Third, you see whether the fibrillary wave is present or absent. 3 criteria. Start. Excellent again. Some people are not answering, 1/3 are answering wrongly. Please remember it is irregular tachycardia. Once you have a irregular tachycardia can happen in only 3 ways. Atrial flutter with varying conduction, multifocal atrial tachycardia, atrial fibrillation. In other 2 tachycardias, you must have a well-formed P wave. Whereas when you do not identify any well-formed P wave. It is only undulating baseline. That means it has to be atrial fibrillation. Only 3 irregular narrow QRS. In other 2, P wave is present, or different type of P waves. Whereas in atrial fibrillation, P wave is absent. Right. So this is atrial fibrillation. We have understood this is atrial fibrillation because RR interval is irregular and my P waves, fibrillary waves are present. And what will you do for this patient? So this, I know this is atrial fibrillation. Rhythm control, rate control, both need more information. So what will do? This ECG is coming to, patient is coming to you first time, and you take an ECG, it is atrial fibrillation. What will you do now? Rate control, rhythm control, or need more information? Start. Excellent. Need more information. You want to know whether it's a recent onset atrial fibrillation, then only you use amiodarone. If you don't know the duration, be happy by controlling the rate. So which of the following should not be given immediately in AF? So that's what I'm asking now, having said the answers. Thought? Excellent. So that is the most important take-home message today, right? Atrial fibrillation, make sure you understand the atrial fibrillation before you expose the drug. So this tachycardia we have already shown you. It is a P wave coming in front of the tachycardia, and it is upright in L1, inverted in AVR, and a biphasic P wave in V1. So all of the following are correct regarding this arrhythmia, except commonest narrow QRS tachycardia, regular tachycardia, preceded by the sinus P wave, easiest arrhythmia to treat the cause, which is a wrong statement here. Start. Answer is, the wrong answer is easiest arrhythmia to treat. This is the most difficult arrhythmia to treat because you have to find the cause. Right, with this we go to the next lecture, and that next lecture is going to be the most difficult of all, and that is going to be on the white QRS complex tachycardia. I said that is, we are going to wade through white QRS complex tachycardia. Whenever, what is the word wade means? Wade means to move or proceed with the difficulty or labor. That's what, when the white QRS complex tachycardia is coming, you have to go through this with a lot of difficulty and labor. So when the people come to learn about ECG, when they opened depolarization and repolarization, they went away from cardiology. They became gastroenterologists and neurologists. When they come to electrical axis or arrhythmias, they went away from the medicine itself to become gynecologists and surgeons. When arrhythmias, when they come to white QRS complex tachycardia, they went away from medical college to become engineers and auditors. So that's what the most difficult topic in the entire cardiology or entire ECG is white QRS complex tachycardia. So you are going to go through this plan. First of all, we define what is white QRS complex tachycardia. Once again, tachycardia means it is atrial rate or ventricular rate more than 100, and now the QRS duration is going to be more than 120 milliseconds. So that is the difference between white QRS and a narrow QRS complex tachycardia. So the white QRS complex tachycardia, the rate is more than 100, the QRS is more than 120 milliseconds. Then how will you classify the white QRS complex tachycardia is once again the same approach, regular or irregular. Regular white QRS complex tachycardia is likely to be a ventricular tachycardia, or sometimes the supraventricular tachycardia is going through the bundle branch block pattern, we say aberrancy. And third will be an accessory pathway which is conducting antegradally to the ventricle, which we call antidromic. When it is conducted retrogradely, I thought orthodomic. Now if it is going to conduct antegradally, it is going to produce a white QRS complex tachycardia. Irregular tachycardia, most common cause will be an atrial fibrillation with a pre-existing bundle branch block, or a atrial fibrillation and antegrade conduction is going to go through the accessory pathway, which is called an antidromic AF. And of course, from the ventricle itself, you have two forms of irregular white QRS, which can be a torsade pointis or polymorphic ventricular tachycardia. So this is a basic approach to white QRS complex tachycardia. So once you decide it is a white QRS complex tachycardia, decide regular or irregular, depending upon your RR interval is regular or irregular. So now we are going to see the mechanism just like we saw the mechanisms of AV and RT. In a white QRS complex tachycardia, a single focus in the ventricle is going to fire rapidly. When this focus is going to fire, it has to depolarize the other sides of the ventricle by traveling through the muscle. Because the impulse is traveling through the muscle, it takes a long time to depolarize the entire ventricles. So that means you have a white QRS complex tachycardia. So that is a ventricular tachycardia. So ventricular tachycardia is one of the white QRS complex tachycardia. Then of course we have the tachycardia which is originating in the above the his. Above the his, it's a supraventricular tachycardia, but the problem is the patient has got a pre-existing bundle branch block. In a bundle branch block, his sinus rhythm ECG itself is going to show white QRS complex. Bundle branch block will have a white QRS complex ECG. When this fellow develops a supraventricular tachycardia, the impulse has to go through just like your sinus impulse through one pathway. What this supraventricular impulse will do? It will go through the intact bundle to the intact ventricle, then travel through the muscle to depolarize the other ventricle. Because one portion of your ventricular depolarization is through the muscle, the QRS is white. Although it is a supraventricular tachycardia, if you have a pre-existing bundle branch block, you have the white QRS complex tachycardia. Then of course, I told you about the accessory pathway. In the previous examples, in a narrow QRS, I told you, antegrade conduction is through the normal pathway and the retrograde conduction is through the accessory pathway. That's why you had a AV-RT, retrograde P wave occurring in the ST segment. Imagine now, my antegrade conduction is through the accessory pathway. What the accessory pathway will do? You will connect the ventricles. So the impulse will come to the ventricles and the ventricular depolarization is through the muscle and not through the accessory path, not through the conduction system. So whenever the accessory pathway conducts antegradely, what will be your QRS? The impulse is going to depolarize the ventricle through the muscle, it will be white. So that also can produce your white QRS complex tachycardia, and this is called antidromic tachycardia. Antidromic means antegrade conduction through the accessory pathway. Orthodromic means retrograde conduction through the accessory pathway. Orthodromic tachycardias are narrow, antidromic tachycardias are wide. So when you come, ventricular tachycardia is the commonest. Next comes the SVT with the bundle branch block, and very rarely we have an accessory pathway mediated white QRS complex tachycardia. It can be sustained or non-sustained. Sometimes you can have a burst of tachycardia, then the sinus rhythm. Whenever the tachycardia is lasting less than 30 seconds, it is called non-sustained. Whenever the tachycardia is lasting continuously like this throughout the ECG, it is called sustained. Then of course you look at in a single particular lead. In a single lead, if all your QRS complexes are same, exactly the same configuration, same direction, they are called monomorphic tachycardias. That means a single ventricular focus is firing rapidly. Monomorphic white QRS complex tachycardia. Whereas look at here. Each QRS is different in shape, direction, configuration. So you can see multiple areas your ventricles are firing. So this is all polymorphic white QRS complex tachycardia. Then the most important differentiation is to look at V1. In a white QRS complex tachycardia, whether I have a positive R wave in V1 or negative R wave in V1. Whenever I have a positive R wave in V1, what happens in right bundle branch block? My V1 R wave is positive, isn't it? So whenever I have a positive R wave in V1 during the white QRS complex tachycardia, I am dealing with what? RBB type of white QRS complex tachycardia. What happens in LBB? V5, V6 is positive, where V1 is negative. So whenever my V1 is negative in a white QRS complex tachycardia, what I am dealing with type? LBB type of white QRS tachycardia. So next step is to see V1. Whether V1 is positive, V1 is negative. V1 is positive means RBB type of white QRS. V1 is negative means LBB type of white QRS complex tachycardia. So how would you classify? We have said it is monomorphic or polymorphic, sustained or non-sustained, and of course V1 positive or V1 negative. Then we come to the most important aspect of approach diagnosis. So approach diagnosis, why this is so important and complex? Because differentiating between SVT with a bundle branch block versus the VT is most important, because many times you have to make this decision very, very quickly. And the decision is very difficult. And another important thing is, if you think it is SVT and this is really VT, and the patient has got a VT, but you think it is SVT, and give drugs like digoxin, verapamil, adenosine, it will endanger the life of the patient. So decision is difficult. It has to be made quickly. It has got huge therapeutic implications. That's why this topic is so difficult. You have to make these decisions very quickly and correctly. So that's what is difficult. So it is not ECG alone which give you a clue whether the white QRS complex tachycardia is VT or SVT. There are a lot of clinical clues if you have time and patience to listen to the patient. Especially when the patient is elderly, he has got a old myocardial infarction, he is coming to you with a white QRS complex tachycardia, 90% of times it is VT. Hypertrophic cardiomyopathy, dilated cardiomyopathy, old MI, patient has got white QRS complex tachycardia, it is VT most often. So if it's a structural heart disease, it is VT. Patient is elderly, most often VT. When the patient has got a family of sudden death, most often VT. Patient has got drugs like cisapride or macrolide antibiotic or tricyclic antidepressants. He comes with a white QRS. Prolonged QT drugs, it is VT. Hypokalemia, hypomagnesemia, white QRS, VT. And there are two clinical signs to say it is VT. Whenever there is a VT, we call this as a atrioventricular dissociation. In VT, what happens is your ventricular pacemaker is firing rapidly at the rate of 200 per minute. At the same time, your sinus node is not idle. It is going to produce impulses regularly because it's a very faithful pacemaker. Whether VT is there or not, it will fire, it is 60 to 100 per minute. So that will fire and will depolarize the atrium. But these sinus impulses cannot come into the ventricle because ventricle is beating faster and is kept at a constant refractory period. So although your AV conduction system is intact, your P waves are not going through the ventricle because ventricle is beating faster and it is not allowing the atrial impulse to go through the ventricle. So what happens? Two pacemakers are working in VT. One is atrial pacemaker, which is sinus node, and another is ventricular ectopic pacemaker, which is producing really the white QRS complex tachycardia. So we call what is known as atrioventricular dissociation. That means atrial impulses are occurring independently, ventricular impulses are occurring independently. Ventricular impulses are occurring rapidly, atrial impulses are occurring slowly because atrial rate is sinus rate, 60 to 100. Here it is ectopic rate, 160, 180, 100, 200. Now what happens is, when they are beating independently, sometimes, only sometimes, the right atrium, both chambers will contract simultaneously. Only sometimes. Both ventricles, both chambers will contract simultaneously. Just like I told you in AV and RT. In AV and RT, for all beats, atrium is contracting along with the ventricle. Whereas in a AV dissociation, only sometimes this will happen. Atrium and ventricle will contract simultaneously. What does it mean? Intermittently, your right atrium will be contracting against the closed tricuspid valve. Only that beat it will show a Cannon wave. So that Cannon wave is going to be irregular. Because only sometimes in AV dissociation, in VT, this happens. Whereas if it is regularly occurring Cannon wave, it is AV and RT. When it is irregularly occurring Cannon waves, it is VT. So just looking at the Cannon wave, even without ECG, we can know what is the diagnosis. right? Then if you auscultate, AV dissociation will have varying intensity of first heart sound, because different portions of your AV closure is happening at different pressures of, that's why AV dissociation, varying intensity. Whereas when you look at SVT, young patients, most often normal hearts, and basic ECG may show a bundle branch block. Basic ECG may show a WPW syndrome, and of course the patient can have what? A Cannon wave. If it is AV1RT, you will have a regularly occurring Cannon waves. But most important thing is hemodynamic stability or instability does not differentiate. Our mindset is VT is hemodynamically unstable, SV it is hemodynamically stable. It is not true. VT can be stable and SVT can be unstable. So now I divide the ECG signs into three things: easy signs, not so easy signs, difficult signs. According to your standard, you can stop at any point in time. For example, you don't want not so easy sign, you can stop with easy signs. You don't want difficult signs, you can stop with the difficult signs. You close your ears. But anyway, I tell all the three. First, we look at the easy signs. The easy signs are whenever your QRS is very broad, it is likely to be VT. Then we have what is known as concordance. V1 to V6, all my QRS complexes are looking same. And we look at the electrical axis. Always we compare the ECG with a sinus rhythm ECG. So that will give a clue. So these are the easy signs. So look at my QRS. So it is a white QRS regular tachycardia, but look at my QRS with, it is occupying one big square, 200 milliseconds. Whenever my QRS width is more than 140 or definitely 160 milliseconds, it is likely to be VT. So very wide QRS, it is likely to be SVT. SVT cannot have this wide QRS. And this is called concordance or RS pattern. For example, in any bundle branch block, you will have a RS pattern. That means any one of the chest leads will show an R wave and an S wave. Because in right bundle branch block you have seen, V1 will show the tall positive wave, but as V6 will show R wave and a S wave. So RS pattern will be there in a typical bundle branch block. Typical bundle branch block, RS pattern should be there. Whereas in LBB, you have V2, V3 will have a R and S wave. Whereas in VT, if the RS pattern and V1 to V6, all your complexes are exactly the same. Everything is positive. V1 to V6, this cannot happen in right bundle branch block or left bundle branch block. Right bundle branch block, V1 has to be positive, V5, V6 has to be terminally negative. Whereas in LBB, V1 has to be negative and V5, V6 has to be positive. So in a typical bundle branch block, V1 to V6 cannot be the same. So V1, V6 the same. It is called concordance. It is VT. Because this is not obeying the typical rule of bundle branch block. SVT, the bundle branch block, what it should do? It should obey the rule of typical bundle branch block. So positive concordance is VT. So V1 to V6, you sign the R waves are the same. Everything is positive, positive concordance, it is VT. Now look at here. V1 to V6, everything is negative, isn't it? So this also cannot happen. So V1 negative means I am suspecting a bundle branch block of left bundle branch type. But my V5, V6 is not positive to say it's a left bundle branch block. So positive concordance, especially negative concordance, it is 100 times, it is almost 99.9% it is VT, negative concordance. So it's easy, isn't it? One is QRS width. See V1 to V6, everything is positive. V1 to V6, everything is negative. Then it is VT. This white QRS is VT. Then look at the axis. For example, if I have a SVT, what is going to happen? My impulse is originating above the his bundle, and the ventricular impulse will be traveling down and left. That means what my AVR will do? AVR will show negative QRS complex if my SVT is producing a white QRS complex area, because the impulse is originating from the above his, and my depolarization ventricle is going to down and left, so it will be going away from AVR. So in a SVT, what will happen is my AVR will have a negative QRS, because SVT impulse will be going away from AVR, ventricle depolarization. But what happens in ventricular tachycardia? My ventricular tachycardia impulse is originating down and left and going up and right to depolarize the other areas of the heart, isn't it? So the impulse is originating here. The impulse is going up towards AVR. So whenever the AVR is positive in your white QRS complex tachycardia, it is likely to be VT, because impulse is originating here and going up here, whereas SVT is originating here and coming away from your AVR. And another important point is this. For example, you have now V1 negative is a LBB type of white QRS, isn't it? V1, V5, V6 is positive. LBB type of white QRS. In LBB type, you always expect a normal axis or a left axis. In a LBB type of VT, you have a right axis. Now you can say L3 is positive here. Now L3 is positive here. LBB type of VT, but I have a right axis. Similarly, right bundle branch block type of white QRS, but I have a left axis. It is VT. So, particular right bundle branch block may have a right axis, particular left bundle branch block must have a left axis in regular tachycardia. So, this is VT. Now, 3 points I told you. My QRS is very wide. Second, I have a concordance. And I have, third is my axis, AVR axis. If you are remembering right axis, it doesn't matter. But remember the AVR axis. If the AVR is positive, it is likely to be VT. AVR is negative, it is likely to be SVT. Then look at the sinus rhythm ECG. If your sinus rhythm ECG, you have a ventricular premature beats happening regularly in a particular patient. And during the white QRS complex tachycardia, your white QRS tachycardic QRS complex configuration is the same as the ventricular premature beat you had during the sinus rhythm. It is likely to be VT. After all, a tachycardia is continuous running of your premature beats. A premature beat is what? A premature beat, then the sinus rhythm comes. Let us imagine the premature beat continuously running without allowing the sinus rhythm to come in. That is a tachycardia. Tachycardia is the extension of continuously occurring premature beats. If your ventricular premature beats are continuously going to occur, it is ventricular tachycardia. So your sinus beat has got a VPD, and the VPD configuration is same as the white QRS complex configuration. Then you are also sure you are likely to have a ventricular tachycardia, and because the VPD is now started running continuously without allowing the intervening sinus beat. So that is about, you can see that configuration, the same configuration of VPD and the white QRS configuration also same. Then look at the bundle branch block. Then look at the bundle branch block. So now, what bundle branch block I had during the normal sinus rhythm, what bundle branch block I had during the white QRS tachycardia matters. Because in SVT with the bundle branch block, during the sinus rhythm and during the white QRS tachycardia, you must have the same bundle branch block, isn't it? Because sinus rhythm itself is going through the particular bundle, let us say it is going through the right bundle branch block. If I have a SVT, it should go through the right bundle branch block only. So, the bundle branch block I had in sinus rhythm should be the same bundle branch block during the white QRS tachycardia. It is likely to be SVT. In contrast, look at this example. During the white QRS tachycardia, I have a positive R wave in V1. What type of bundle branch block white QRS is this? RBB type of white QRS tachycardia. But during the sinus rhythm, what bundle branch block I had? V1 negative, V5, V6 is positive. V1 negative, V5, V6 is positive. What bundle branch block I have in sinus rhythm? LBB. So if it is SVT, I cannot have a RBB type of white QRS tachycardia when I have a LBB in my sinus rhythm. So different bundle branch block patterns during white QRS and sinus rhythm, it is VT. Isn't it? So V1 is negative there, V1 is positive here. So LBB there, RBB here, it is VT. Very logical. Whereas look at this example. During the white QRS complex tachycardia, I have an LBB pattern because V1 is negative, V5, V6 is also a positive. V1 is negative. So I have a LBB type of white QRS complex tachycardia. What bundle branch block I had during the sinus rhythm? LBB. So I have the same bundle branch block pattern in sinus rhythm, and the same bundle branch block pattern is also happening during the white QRS. It is likely to be SVT. So look at V1 alone. If the V1 is same during the white QRS and also during the sinus rhythm, it is SVT. V1 is positive and negative here, or negative there and positive here, then it is also a VT. So very simple. So what bundle branch block I had during the sinus rhythm? Whether the same bundle branch block is happening or the opposite bundle branch block pattern of white QRS complex is happening decides its VT. So same bundle branch block or a different bundle branch block, right? So that's all the EC signs are about. The EC signs, are you happy? Very wide QRS, and also the concordance is so easy, isn't it? The axis is so easy. Then look at the VPD in the sinus rhythm. Then look at what bundle branch block I had during the sinus rhythm, what bundle branch block I had during the white chorus. That decides VT. Now we go for not so easy signs. Some of you can shut your ears. So if you don't want to know about them. So that's the most important point is AV dissociation, capture beats, and whether we have a typical bundle branch block pattern. So what is the concept of AV dissociation? I told you already, in VT means you have two pacemakers. In SVT, a single pacemaker. That's a concept. SVT, a single pacemaker is coming through the bundle branch block pattern. Whereas in VT, I have the sinus node controlling the atrium, and I have a ventricular ectopic pacemaker controlling my ventricle. So there is independent beating of atrium and ventricle, independent depolarization of atrium and ventricle. So I have atrioventricular dissociation. So this is what we mean. Atrium and ventricles are depolarized by two different pacemakers. Sinus rhythm is depolarizing the atrium, and the ventricular pacemaker is depolarizing the ventricle at a very rapid rate. Because the ventricles are beating at a very rapid rate, although my AV conduction system is intact, my atrial impulses are not able to go through the ventricles. So they are occurring at a very slow rate of 60 to 100 per minute, and this is happening around 80 to 200 per minute. So I have independently occurring P waves, independently occurring QRS. So I have to demonstrate no fixed relationship between P wave and the QRS. That's called atrioventricular dissociation. So the atrioventricular dissociation tells you a very important point is what? Two pacemakers are working. When two pacemakers are working, it is VT only. You cannot have AV dissociation when I have a SVT with the bundle branch block, because a single bundle branch, all the impulses have to go through the bundle branch pattern only, single pacemaker only. I cannot have AV dissociation. So that is an important point. What you have to do is, so this is what we told you. So the ventricle is beating faster, independently my atrium is beating, and the sinus node is depolarizing the atrium, and the rapid ventricular pacemaker is depolarizing the ventricular pacemaker. So because the ventricles are kept at constant refractory period, although my impulses are coming at AV node, it cannot go through the ventricle. So this is, whenever you demonstrate two pacemakers are working in the form of atrioventricular dissociation, it is likely to be VT, because in AV dissociation, you are demonstrating two pacemakers are working independently. That cannot happen in SVT. In SVT, it's a single pacemaker. Now look at this electrocardiogram. I have a white QRS complex, regular tachycardia, but I have to carefully see whether I have independent P waves. You can see one P wave here in front of the QRS, another P wave just coming in the ST segment, another P wave coming just before the QRS. So I am demonstrating P waves all right, but they are occurring independent portions of your QRS complexes. There is no relationship, fixed relationship between the P and the QRS. And another important point is, look at my P wave rate. It is almost 70, 80 per minute. Look, my ventricular rate is 100 or 200 per minute. So ventricular rate is faster, atrial rate is slower. But the atrium cannot go through the ventricle. Whenever you have a AV dissociation, it is likely to be VT, because it demonstrates two pacemakers are working. SVT, it's a single pacemaker going through the bundle branch block pattern. So that's what in any VT, white QRS, you must, because it may not be so obvious. You can see the small blips here. Can you see that small blips? So your eyesight must be so accurate to pick up the small blips. These are the blips of independently occurring P waves. So you can see that here, that single point will tell us this is a P wave occurring in one portion of the QRS without any relation to QRS. So it is likely to be VT. Then of course, what happens is, although I told you that my beats may not come to the ventricles, a lucky sinus beat may find a small responsive period between two QRS of my white QRS and sneak through. A lucky sinus beat, very lucky fellow, will find a gap between two QRS, a small responsive period, and may sneak through. When it sneaks through, what the sinus beat will do? It will go through the normal conduction system. The sinus beat will go through normal conduction system, isn't it? That means that sinus beat will have a what QRS? When it goes through the normal, what QRS? Narrow QRS. Whenever the sinus beat is capturing the ventricle, it will have a narrow QRS. So in the presence of a white QRS complex tachycardia, I suddenly find one QRS complex which is narrow. What does it mean? My sinus beat has captured the ventricle going through the normal conduction system. Can this happen in SVT? Cannot. Because I already have an established bundle branch block. So all the beats have to go through the bundle branch block pattern only. I cannot have a narrow QRS in between the white QRS complexes in VT, in SVT, isn't it? So whenever I find a narrow QRS complex in the presence of a wide QRS complex tachycardia, it means my sinus impulse have captured the ventricle, and the sinus impulse is going through the normal conduction system to capture my ventricle, and that will have the narrow QRS complex. So one lucky sinus impulse will find a gap in refractiveness, may go through the ventricles. This sinus impulse will go through the normal conduction pathway, so it will have a narrow QRS. So what you have to see next, in the addition to AV dissociation, in the presence of a basic wide QRS complex tachycardia, I suddenly find a QRS complex which is absolutely narrow. Whenever I see this, that means I am demonstrating once again two pacemakers. My sinus pacemaker is going through the normal pathway, resulting in the narrow QRS. So whenever I have this narrow QRS complex in between the wide QRS complex, it is VT. SVT cannot happen at all, because all beats have to go through the established bundle branch block only. You cannot have a narrow QRS in between. So this is called the capture beat and the fusion beat. So first is a AV dissociation. See carefully, suddenly I find a beat which is narrow in the presence of a basic wide QRS tachycardia, then also it is likely to be ventricular tachycardia. So that is your narrow QRS beat in the presence of a wide QRS complex tachycardia. So AV dissociation, the problem is it can happen only in 30% of patients. The absence of AV dissociation does not exclude VT, because many times what happens is this ventricular tachycardic beats will be constantly conducting the impulse retrogradely and do not allow the sinus impulse to come out. So that's why the difficulty is so that. Then we look at whether it's a typical bundle branch block pattern or atypical bundle branch pattern. What we mean by typical bundle branch block pattern is triphasic pattern. Most often if it is RBB, you will have R, S and R dash. So it's called triphasic pattern, initial septal depolarization, ventricular depolarization, late right ventricular depolarization. And another important point is, in a SVT, my terminal R wave will be always taller than the initial R wave, because the terminal R wave is the one which is the depolarization of the last ventricle for which the bundle is blocked. So it will be large and broad, because this impulse is conducted through the muscle. So whenever my terminal R wave, triphasic pattern, my terminal R wave is taller than the initial R wave, it is likely to be SVT. Whereas in VT, most often it is a single R wave, monophasic pattern. Single R wave, not this classical triphasic pattern. Even it is a biphasic pattern like this, I have a biphasic pattern, my initial R wave will be taller than the terminal R wave. So if my initial R wave is taller than the terminal R wave, then also it can be VT. Some people say right rabbit rear, left rabbit rear, so that's all confusion. We know which are now, whether it's the right side of the slide or your right side. So we say initial R wave, terminal R wave. Terminal R wave is tall, SVT. Initial R wave is tall, VT. Monophasic pattern, it is VT. Triphasic pattern, it is SVT. So this is what the typical bundle branch block or not a typical. In a typical bundle branch block, your terminal R wave is always taller than the initial R wave, whereas atypical, the initial R wave is taller. This is called the Marriott sign. The terminal initial R wave is taller than the terminal R wave is called the Marriott sign. Now we come to the difficult sign. Many of you may close your ears. So having seen that AV dissociation, we come to the difficult signs which are called morphological criteria to diagnose the ventricular tachycardia versus SVT, the bundle branch block. So I told you here only my application will come, RBB type of VT or LBB type of VT. So what the points to be applied, whether it is VT or SVT. First we look at the RBB type of VT. I told you triphasic pattern. What does it mean? And what is my R wave? Terminal R wave is taller than the initial R wave. But when you look at V5, V6, my R wave in V5, V6 is taller than the depth of the S wave in a typical SVT with a bundle branch block. My V5, V6 R wave will be taller than the S wave in a typical, because this is actually obeying the rule of typical bundle branch block. Triphasic pattern, my R wave in V5, V6 is more than the S wave, or RS ratio is more than 1 in V5, V6, it is likely to be SVT. Whereas I have a monophasic R wave complex in V1, but the most important is V5, V6. In RBB type of VT, you have to look at V5, V6. In V5, V6, My R wave is small, my S wave is very deep, it is VT. This cannot happen in right bundle branch block, which is classical. So whenever in RBB type, concentrate on V5, V6. My R wave is small and the S wave is deep, my RS ratio is less than 1, it is likely to be VT. So in RBB type of white QRS, what lead you are going to concentrate? V5, V6. R wave is tall, SVT. S wave is deep, VT. So this is a morphological criteria. Now we come to the LBB type of white QRS complex tachycardia. So for that you have to concentrate on V1. RBB type you have to concentrate on V5, V6. LBB type you have to concentrate on V1. So in V1, in a classical SVT with a left bundle branch block, your initial R wave will be very sharp. Initial R wave will be very sharp. That means it will not be just occupying one small square. And when you have this S wave, there will not be any notch in the descending limb of the S wave. And what happens is the distance between the R wave and the S wave will be less than 60 milliseconds. Very quickly, the peak of the S wave will be reached in SVT. Very quickly, the peak of the S wave will be reached and there will be no notch. In a classical left bundle branch block, there will not be any Q in V5, V6. In a classical left bundle branch block, there is no negative wave in V5, V6. So you don't have a Q at all in V5, V6. So this is, whenever this happens, it is LBB pattern, my initial R wave is sharp, I don't have a notch in S wave, quickly my peak of the S wave is reaching from the R wave, it is SVT. Whereas in VT, what happens? My initial R wave is very broad. It is occupying more than 30 milliseconds. I have a notch in the descending limb of the S wave. And the distance between the beginning and the nadir of the S wave is very long. And it takes a long time for my S wave peak to come late from the beginning of the R wave. It is likely to be VT. Right? So initial R wave is broad. I have a notch. And the distance between the R wave and the S wave is longer. It is VT. And you have a Q wave in V5, V6 in VT. In a classical LBB, you should not have a Q wave. Whereas in a VT, you have a Q wave. So these are the, so I just wanted to, so make a CT, I want to concentrate to this. In RBB type of white QRS, concentrate on V5, V6. In LBB type of white QRS, concentrate on V1. Now we see the examples. Right, we'll see the examples now. Now we look at here. So LBB type, I concentrate on V1. My initial R wave is very broad. I have a notch in the descending limb of the S wave, and the distance between the beginning of the QRS and the peak of my S wave is very long. It is likely to be VT. It is likely to be VT. Look at this white QRS complex tachycardia. I concentrate on V1. What is my initial R wave? Wide. What is there? Notch. What is here? V5, V6. Q. So what is it? VT or SVT? VT. That's all. My initial R wave is broad, notch in the S wave, and I have a Q wave in V5, V6. It is likely to be VT. So this is for LBB type of white QRS complex tachycardia. So now I have a RBB type of white QRS complex tachycardia. So I have a triphasic pattern in V1, and my R wave in V5, V6 is taller than the S wave. So what is this? It is written here. What is this white QRS complex tachycardia? Triphasic pattern. I want to concentrate on V5. My R wave is taller than the S wave. It is SVT. Whereas look at here. I have a right bundle branch of white QRS complex tachycardia. I have a monophasic R wave. What is happening in V5, V6? My R wave is very small and my S wave is very deep. So this RBB type of white QRS complex tachycardia is VT. So look at V5, V6. Difference between this V5, V6. Look at here and look at here. So triphasic pattern, terminal R wave is taller, and I have the R wave taller in V5, V6, it is SVT. Monophasic R wave, my S wave is deeper than the R wave, it is VT. So this is for RBB type of white QRS complex tachycardia. So there are a lot of complex algorithms. If I tell your complex algorithms, you will go home. You will not attend the further conference here. So you will go home. So I will not go through all this. So I'm just giving an example here. I have a white coarse now. V1 is positive. What type this is? RBB type or LBB type? RBB type. What I must concentrate? V5, V6. My S wave is very deep. VT or SVT? VT. All. So I concentrate on V5, V6. My R wave is small. S wave is so deep. So this is RBB type of white coarse tachycardia. It is a VT. Monophasic R wave in V1, not triphasic pattern. Right? So V5, V6, my R wave is small and the T wave is VT. Now look at RBB type of white coarse tachycardia. What is happening in V1? Triphasic pattern, RSR dash. What is my terminal R wave? Terminal R wave is taller than the initial R wave. What is happening to V5, V6? You look at here. R wave is tall or S wave is deep? R wave is tall. So what is it? SVT. That's all. So just in RBB, look at V5, V6. In LBB, look at V1. That is the morphological or difficult sign. Now I am giving you this example. So here it is a V1 is negative, V5, V6 is positive. So it's a LBB type of white coarse tachycardia. You think it is VT, but carefully see that initial R wave. I just expand that here. So I just expanded here. See that initial R wave. So sharp. Look at the S wave. No notch. So this is SVT or VT? SVT. Right? So although it looks like a VT, very small point. See that initial R wave. So sharp. This cannot happen in VT. It will be broad. Right. So that finishes our regular QRS tachycardia. The notch in the S wave is called the Jefferson sign. So this is called the Jefferson sign, and that notch and the initial broad R wave. So you can see that here the R wave is broad and there is a notch here. So these are the multiple points I have told you: AV dissociation, morphological criteria, QRS duration, and positive or negative concordance, abnormal axis to the bundle branch block, and also what bundle branch block you had in sinus rhythm and what bundle branch block you had in the white coarse tachycardia. Then we come to the white coarse tachycardia of the accessory pathway type, antidromic tachycardia. Now what happens is my impulses are coming through the accessory pathway antegradially through the ventricle, and from here the ventricle should be activated through the muscle. So if I have a flutter here, atrial flutter here, all my flutter waves will come through the accessory pathway, so to the ventricle, and this impulse is going through the muscle, so I have a white coarse complex tachycardia. Although it is atrial flutter, which is supposed to be narrow QRS, I have a atrial flutter. So the clue here will be the accessory pathway will not have the protection like AV node. It will not block the impulses. What is the function of AV node? It will block number of supraventricular impulses so that it will not allow more impulses to the ventricles. So I have a very rapid rate when I have accessory pathway because no AV node protection. So this is the white QRS complex tachycardia. You can see regular tachycardia, but the important clue is the rate. You can have the rate of 300 per minute. This cannot happen with the intact AV node. So whenever you have a white coarse complex tachycardia with a very fast heart rate, although it is regular, very fast heart rate, it is likely to be flutter conducted through the antidromic pathway, antidromic atrial flutter. So you can see that here. Then we come to the irregular narrow QRS tachycardia. The most common irregular narrow QRS tachycardia is atrial fibrillation. In atrial fibrillation, a patient has got already existing bundle branch block. So all my fibrillary impulses will go through what? It will go through the typical bundle branch block pattern. So patient will have a white QRS complex tachycardia, but irregular tachycardia, irregular white QRS. Here I have a LBB type of irregular white QRS because V5, V6 is positive. Now what is very important is to differentiate between three types of irregular white QRS. You must look at three things. What is my QRS in a given single lead? You take a single lead and see the QRS. They are same configuration, same direction, and same width, the three things. So I'll take V5, V6. All my QRS complexes are upright. That means direction is same. All my QRS complexes are same width. So, and also they have a same configuration. So all the three are good. My direction is good, width is good, configuration is same. it is likely to be atrial fibrillation with a pre-existing bundle branch block. And the rate is always less than 140 or 160 because AV node will not allow my 300 impulses to the ventricles, isn't it? So my heart rate will be always less than 140 to 160. It is likely to be atrial fibrillation with a bundle branch block. Then we come to this. I once again have a irregular narrow QRS complex tachycardia. But what is very important, see the rate here. My rate is 300. That means these impulses are not coming through AV node. That means impulses are coming through or here atrial fibrillation happening. All my fibrillary impulses are coming through the accessory pathway to the ventricle and the atrium is beating around 350 per minute. All the 350 impulses are coming to the ventricle. Very high, very rapid heart rate. Atrial fibrillation, the ventricular response is more than 200. It is likely to be antidromic AF. Your fibrillary impulses are coming through the AV node. And what is very important to see this, although I have the same direction of the QRS, each QRS is different in character. You can see something is narrow, something is wide, something is different. They don't have the same configuration in the given lead, but the direction is same. When they are negative, they are negative. But the configuration is keep on changing. My heart rate is more than 200, then it is an AF conducted through antegradally accessory pathway, antidromic AF, very dangerous AF, and the most important therapeutic implication is here you don't give AV nodal blocking drugs like digoxin, verapamil, diltiazem, and adenosine because that will block already existing AV node, allow more impulses to come through the antidromic AF. So here most often DC shock or some other drugs. And this is a polymorphic VT. What happens in a single given lead, I have the direction is different, some direction is upright, some direction is down, and I have the configuration is changing, direction is changing, and also width is changing. Whereas in AF with antidromic, what happened? Only my configuration changed. The direction was remaining the same. Everything was negative, but the configuration was changing. But here the configuration is changing, direction is changing, and also width is changing. It is polymorphic VT. Most common polymorphic VT is tarsi adipointis along with a long QT interval. Most often precipitated by long QT interval is tarsi. Polymorphic VT is the third important differential diagnosis of wide QRS, narrow QRS complex tachycardia. Whenever this happens, go through the drugs the patient is taking. Many drugs will prolong QT interval. So whenever there is a wide QRS tachycardia, look at the rate. Rate is around 140 to 160. Your configuration is same, direction is same, width is same in a particular given lead. It is AF with a pre-existing bundle branch block. I have a very fast heart rate, 300 per minute. My configuration alone changing, direction is not changing. It is antidromic AF. My direction is changing, width is changing, my rate is changing. It is polymorphic VT of tarsi adipointis. And of course, we have arrhythmia called ventricular flutter. The difference between ventricular flutter and ventricular tachycardia is in flutter, you will see only the QRS and not the T wave. Whereas in a classical VT, you will independently see the T wave. So see the difference? You will see the QRS and the T wave. If you don't see the T wave at all, it is ventricular flutter, should be treated just like your ventricular fibrillation. And the last arrhythmia. This is the last arrhythmia of our class. And many times you would have lost the patient because of this arrhythmia. This is a ventricular fibrillation, no electrical activity occurred. So everything, no P wave, no PR interval, no QRS complex, everything is a chaotic baseline. So this is a cardiac arrest. So what you must do is immediately cardiocerebral resuscitation, not DC shock. Immediately start a cardiocerebral resuscitation. Then somebody brings the DC shock. First 3 minutes, 100 compressions per minute, don't interpret in a primary cardiac arrest. There is no CPR for a primary cardiac arrest. It is CCR, cardiocerebral resuscitation. Your job is to restore the circulation and effective compression. Don't even for a second interrupt your cardiac compression for first 3 minutes. Give shock and don't look at the monitor. Keep on pressing the patient. So the end point of our success is when the patient beats you. That is your end point of our success. Because as you restore the cerebral circulation, patient becomes conscious and see somebody is pumping him, he will beat you. So the only time you are happy when somebody beats you is when you give a cardiac compression and the patient becomes conscious is the end point of resuscitation. Not appearing the QRS in the monitor is your end point of resuscitation. So now we have the management. If you are not sure about any of the signs, treat as VT. Then you may say, why did you talk about 45 minutes? With the white QRS complex, I'm not sure I can treat it as VT because of two reasons. 80% of times your white QRS complex is VT. Second point is, I told you SVT drugs are dangerous to VT, but VT drugs are not dangerous to SVT. VT, what you are going to give? You are going to give amiodarone. Amiodarone is not good. It is going to be acting for SVT also. That's why if you are not sure, treat it as VT. I'll tell you so many signs. In spite of that, you are not sure. Treat that as SVT and not VT, not SVT. Monomorphic stable, lignocaine, amiodarone, polymorphic. Please remember this important lesson. In any white QRS complex area, when you are not sure, don't give verapamil, digoxin, and indenosin. Amiodarone is a better choice. You have a long time definitive electrical treatment. And takeaways is this: whenever you have a white QRS complex tachycardia, QRS and T waves are present, then it is a VT or SVT with aberrancy. So we have told you the differences are antidromic atrial flutter. So in the QRS alone present is ventricular flutter, and no QRS and T wave, it is ventricular fibrillation. I'm sure you are like this now because of so much of input here. So we briefly run, our time is up. We briefly run our voting part session, then we will finish off the course. So quickly, Sebastian will start. Up to 11, I will do this and stop at 11. So my first question is like this. All of the following are white QRS complex tachycardia, regular tachycardia except. All of the following are white QRS regular tachycardia except. Start. Excellent. Tarsidy pontis is a irregular white QRS complex tachycardia. Which of the following is not the feature of VT? Intermittent Cannon waves, constant intensity of S1, previous myocardial infarction, elderly. Which cannot be VT? Start. Right, excellent. The varying intensity of a short sound. I am giving a ECG here, and you can see that. I'll just take. Carefully see, I am showing one beat here. I am showing one beat here. Basically, white QRS complex, I am showing a beat here. See that beat? What is that beat? Is it narrow QRS? So what is this beat? Escape beat, capture beat, neither or either? In the presence of a white QRS complex tachycardia, suddenly you find a narrow QRS beat. What is it? Start. You are so good now. So you are able to pick up a capture beat. So that's the most difficult thing in cardiology. So it is likely to be VT or SVT. When you have a capture beat, it is likely to be VT or SVT. VT, because a sinus beat has gone through a normal pathway. In a SVT, the bundle branch block, this cannot happen because all the beats have to go through the bundle branch block. You cannot have a narrow QRS in between a white QRS beat. Right, it's a capture beat. Now, this is basically a white QRS complex tachycardia. What I have shown you is the expanded portion of my V1. See that initial R wave. See the downslope of my S wave. It is a LBB type of white QRS complex tachycardia. See that initial R wave. Look down the S wave, how smooth it is. Look at the initial R wave. You think it is SVT, the bundle branch block, VT, or SVT, the pre-excitation, or Tarsidy pontis. So look at the initial R wave and the S wave. Start. Excellent. So that's what the most difficult ECG is about. People will think it is VT. But look at that initial R so sharp. Look at this S. What is that sign called? The notch in the S wave. Josephson sign. So there is no notch. You can see the beautiful, very fast up down slope of S wave. So it is likely to be SVT with a LBB. Now, white coat has come tachycardia. I have shown certain things here. Some blips are happening here. What is those blips? Yes. So now you tell me what? It is VT, SVT or WPW. Start. Excellent. So some of you are answering for SVT aberrancy. Why it is not SVT the aberrancy is, once again you see the point. Even you don't look at AIB dissociation, it is a RBB type of white coat, isn't it? V1 is positive. Then what?
Any other? Ma'am, yourself.
ASV, how many vials are used for?
So I am professor and HOD of medicine, Kanyakumari Medical College. There we used to get patient present with snake bite and initial cellulitis, but the whole blood clotting time is normal. But the next day when we check late anonymization, so clotting time is prolonged even after 24 hours.
Yes, sir.
How to proceed with it?
We are coming at that, sir.
Yep. Sir, Soundrajan, sir. Any questions? Yeah.
ASV
induced
induced
anaphylaxis.
anaphylaxis.
Okay.
Good.
Anything you can ask before?
ASV
Renal
induced renal failure.
Okay.
Okay.
Any questions? Because it's an interactive session, almost 50 questions we have.
Yeah, okay.
We will be
vials.
answering.
Yes. Yes.
Fine.
We'll do that.
Any questions?
So most of you all, everybody are having one question in doubt. So we will go through, these are the questions. Actually, we did this in critical care forum. These are the questions asked by the critical care residents to me. So I am trying to answer all your questions. If I am missing, you can ask any other questions, okay? So the first is indication for ASV. So Palanipan sir.
Yeah, indications of ASV, when you have to give, whether the patient is having, if you suspect the patient is having snake bite, definitely you have to give. But whether it's a tri-snake bite or crate-induced snake bite, or if you are not able to detect early, all things it will come into your mind. So indications of ASV, if there is no snake bite, you cannot give ASV. But many times unknown bite, some of the situation, it may be scorpion sting or snake bite. So scorpion sting and snake bite, very important immediately, because it's a hit hard, hit fast rule has to be applied. The important thing is, very, very important thing is, if it is radiating pain, profuse sweating and priapism, more in favor of scorpion sting. The particular situation, கரையில் நடந்து போகிறாங்க, அப்போ எல்லாம் டெஃபினட்டாக ஸ்னேக் பைட் தான் யூ சஸ்பெக்ட். கல்லுக்கடியில் ஏதோ கையை விட்டாங்க, இல்லை உப்பு எடுத்தாங்க, கிச்சனுக்குள்ளே எடுத்தாங்க, இதெல்லாம் வந்து ஸ்கார்பியன் ஸ்டிஞ்ச். ஸோ சிவியர் பெயின் வித் ப்ளீடிங், ரெண்டு பைட் மார்க் இருந்துச்சு அப்படின்னா மோர் இன் ஃபேவர் ஆஃப் ஸ்னேக் பைட். அப்புறம் அந்த 1/2 சென்டிமீட்டர் டிஃப்ரென்ஸு, ஃபேங் மார்க் இல்லைன்னா டசன்ட் ரூல்ஸ் அவுட் ஸ்னேக் பைட். ஹேண்ட் ஹேட் மைக்ரோ இதில் லென்ஸ் வச்சுட்டு யூ ஹேவ் டு சி. ஏன்னா மெனி டைம் கிரைட் பைட்டில் ஃபேங் மார்க் வில் பி தேர், it may not be seen in your naked eye. So later on, few hours you will have a abdominal colic, vomiting, hypertension, dilated people, crate bite and lymphadenitis. இதெல்லாம் தான் இருக்கும். So first வந்து indication of snake bite வந்து snake bite இருக்கு அப்படின்னா தான் you have to give ASV. Otherwise don't give. But some of the indication without some of the clinical manifestation, the crate also one of the indications for giving ASV. We will come to you later. So indications for ASV, you have to differentiate between snake bite and other bites, any bites. So bee sting also will be there, or scorpion, very commonly, profuse sweating. You have to differentiate these 3 points. அது எந்த சூழ்நிலையில் கடிச்சது, அப்புறம் கவ்வன மாதிரி இருந்துச்சு, பாம்பு கடிச்சு கவ்வன மாதிரி சொத்துன்னு விழுந்துச்சு, இதெல்லாம் மோர் இன் ஃபேவர் ஆஃப் ஸ்னேக் பைட். ஏன்னா அன்னோன் பைட் தான் ரொம்ப ரொம்ப காமன், தே வில் ஹேவ். அப்புறம் தேவில் உன்னையே டெஸ்ட் பண்ணுவாங்க, நீ உண்மையை கண்டுபிடிக்கிறீங்க. ஏன்னா ஏஎஸ்வி ஸ்னேக் பைட்டுன்னு சொல்லிட்டோன்னா லேக்ஸ் டுகெதர் செலவாகுங்கிறதுக்காக தே வில் ஹைட் த ஹிஸ்ட்ரி. அப்புறம் பின்னாடி என்ன பண்ணுவாங்க, தே வில் ஆஸ், நான் எதமாக்கு இருக்கேன்னு தெரியல, நீ கண்டுபிடிக்க வேண்டியதானே, ஏன் இப்படி விட்டுட்டா, எப்படி கிட்னி ஃபெயிலியர், எப்படி டெத் ஆச்சுன்னு கேள்வி கேட்பாங்க. ஸோ ப்ராப்பராக ரெக்கார்டிக்கலி இருக்கணும். யூ ஹேவ் டு கிவ் எம்எல்சி, போலீஸ் இன்டிமேஷன் ஷுட் பி கிவன், ப்ராப்பர் ரெக்கார்ட் ஷுட் பி தேர். ஸோ unknown bite, unknown bite. So எல்லாம் history is taking is very, very important. Sandhil, you can add.
Yes, sir. Regarding indication for ASV, you need to have 2 things. One is clinically documented envenomation. and it should be supported by your lab parameter. Okay. So clinically clinically showing envenomation like patient is having an ascending swelling, not just swelling is sufficient. Okay, this swelling can be caused by any other insect, any other arthropoda bite can cause, like a bee sting or a scorpion or bumblebee or even any other thing, even thorn prick going for a secondary cellulitis can cause a swelling. So whenever there is a ascending swelling, that is the first point. Second, in few cases, the patient will not have a ascending swelling or not even a swelling, but they will develop blisters. Okay, blister is another indication that it is a snake bite, you have to give ASV. This is a second thing. Third, the patient will have a tender lymph nodes. Okay, even any other bites will not have a lymph nodes. Okay, they will have a tender lymph nodes. And fourth one is the patient can have some kind of bleeding manifestations. It is not mandatory that all the snake bite will have a bleeding manifestations. Even a cobra or even a kite, even sometimes saw-scaled viper will not produce overt bleeding. And very, very important that just seeing 2 fang mark is not an indication that it is a venomous bite. Even many times non-venomous bite will have a 2 fang mark. Okay, that old school of thought, the forensic textbook says that multiple fang marks, even we have seen multiple fang marks in a cobra bite. Okay, so whenever it is trying to bite, when the patient is having a reflex action, they will have 3 or 4 bites will be there, just tear mark. So you should be very careful in analyzing it. That is clinically. Laboratorily, you can go for 20 minutes whole blood time or PT-APDT. As sir rightly pointed out, most of the snakes, okay, they will have only local swelling, some snakes, especially in the summer time. Okay, they will not allow you to go for an immediate bleeding complications. So they will have a localized swelling that can be easily picked up by APTT. Okay, when you are doing APTT and prothrombin time, it will pick you out before your 20 minutes whole blood time. So it is always advisable, if your facility has to do PT-APTT, please do PT-APTT rather than waiting for 20 minutes whole blood time. Okay.
அப்புறம் 20 WBCT தான் gold standard.
Yes, sir.
Because periphery also it can practice. But gold standard is PT-INR, APTT, PT-INR. That's very, very important. If in your lab it's available, definitely that is the gold standard. Many times there are lot of false thing will be there, so that's very important. You have to keep it in mind. And tender lymph node, because it's a lymphatic drainage. Tender lymph node is very, very important. But scorpion's sting also may get, but a severe tender lymph node will be more common in the snake bite. That's very important. Bleeding may be there or may not be there. And fang mark alone, if it is present, it's not an indication to give ASV. Because multiple can be there and without bleeding may be there. But if bleeding is there, more in favor of snake bite. But usually scorpion sting may not be there. So that point of care, you should be very careful in using the words. If you are not confident, don't tell that unknown bite, we are investigating, let us know. Like that you give. Unnecessarily if you give, then you will be in the litigation. So you have to be very careful in giving. There's an indication of ASV is very, very important. Okay, what is a dry bite or false snake bite? Dry bite means பாம்பு கடிச்சிருக்கும் ஆனால் விஷம் உள்ளே போயிருக்காது. பாம்பு கடிச்சிருக்கும் விஷம் உள்ளே போயிருக்காது. அப்புறம் என்வீனமஸ் பைட், ஸ்னேக் பைட், பச்சை பாம்பு இதெல்லாமே கடித்தாலும் ஃபேங் மார்க் இருக்கும், there will not be. Then always any snake bite, அதாவது venomous envenomation, it will be lymphatic drainage, through lymphatic drainage only it will go. So crate bite la there may not be, crate bite la early phase la there may not be ant bite மாதிரி இருக்கும். காலையில் விடிய காலமாக 2 மணி 3 மணிக்கு திண்ணையில் படுத்திருந்தேன், ஏதோ கடிச்சுது. 2 கேஸ் எல்லாம் ஜஸ்ட் வந்தாங்க, ஒன்றும் இல்லை ஏதோ கடிச்ச மாதிரி இருந்துச்சு, செக் பண்ணிட்டு போகலான்னு வந்தோம் அப்படின்னு சொல்லுவாங்க. உடனே 24 to 40 hours அப்சர்வேஷன் இருக்கணும், அன்னோன் பைட்டு ஏதாவது இருந்துச்சுன்னா. பிகாஸ் இல்லை எனக்கெல்லாம் நல்லா இருக்குது போகிறேன்னு சொல்லிட்டு காலையில் 6 மணி 7 மணிக்கு பல்பார் பால்சியோட தே வில் ப்ரெசன்ட், ட்ரூலிங் ஆஃப் சலைவா, இன்னபிலிட்டி டு டாக் எல்லாம், பல்பார் பால்சி எல்லாமே. பிகாஸ் ophthalmic paralysis, respiratory paralysis order, they will come. Usually children, elderly individual, even adult also, they will come. Namma recordically 24 to 48 hours unknown bite, get admitted observation. Because initially tender node may not be there. கொஞ்சம் கொஞ்சமாக tender வரும் and abdominal colic, vomiting, hypertension and lymph node enlargement இதுவும் indication for giving ASV. Without cellulitis இல்லாமலே you can give. There is a WHO criteria are there. So here falls or dry snake bite. இதில் வந்து without envenomation you should not give. Exception is crite. Exception is crite. Criteல PTINR may not be elevated. Then 20 WBC also negative. So இல்லைனா எப்படி கொடுக்க முடியும் அப்படிங்கிறது தான். So இந்த இண்டிகேஷன்ஸ்னால you have to give. But ஸ்னேக் கடிச்சதுன்னா எல்லா பாம்பும் அதில் வாயில் இருக்கிற எல்லா விஷத்தையும் கக்குன்னு சொல்ல முடியாது. நிறைய டைம் வந்து பைட் இருக்கும். நோ இட் மே நாட் இன்ஜெக்ட். ஸோ இட் மே நாட் இன்ஜெக்ட் அப்படின்னா யூ நீட் நாட் கிவ் ஏஎஸ்வி அட் ஆல். யூ கேன் ஆட் செந்தில்.
Actually, sir has clearly told about dry bite. There is another entity called false bite. Okay, I put particularly false snake bite, especially in the north, and now it is picking up in our area, especially in Congo belt. We are seeing lot of people. There is a thorn, vivasayam mullu. Okay, and that will contain a big thorn. So they would have been borrowed some money and they are not able to pay. So what they will do is they will come to a hospital with a 2 fang mark. Okay, just like a snake bite, they will come with a 2 fang mark, and the local cellulitis will be there. Okay, warmth will be there. This, and when we see this patient, other things will not be there. Tender, multiple time we do bleeding time, clotting times, and all. Everything will be normal. No bleeding manifestation will be there. PTA, PTT will be normal. When we say this is not a snake bite at all, they will refuse. Okay, they will say no. I have witnessed it is bitten by a cobra. Okay. So you need to be very careful in certifying them whether it is a snake bite or it is snake bite like picture. Okay, medical legally. And sir told all snake bite has to put as an MLC. Now DGP has given a clear instruction, no need to put MLC at all. Okay, so no MLC unless you suspect there is a foul play in that. Otherwise, no need. We have witnessed a few cases where the snake charmers getting suicide with the snake. Okay, they will try to attempt suicide with the snake, or they will being hired as a homicidal people for putting a snake in a different area. Even we had received 2 patients. Their husband was engaged to put a snake in the wife's room, where the snake went and bite, and then later it was identified by the mother-in-law, and then patient treated. Then it has happened. Same thing happened in a brother putting a snake in the other brother's thing, because of the sibling rivalry. So you need to be very cautious. Just don't put, unless you think that there is no foul play, there no need for MLC.
I accept Senthil's point. In our hospital, I have not given the intimation, cried bite, intubated, but 3rd day patient expired. But police station ஏன் intimation கொடுக்கல? Because snake bite தான் கடிச்சிட்டு நீ வெண்டிலேட்டர் போட்டு சாகடிச்சிட்ட, நீ இம்ப்ராப்பர் ட்ரீட்மெண்ட்னால செத்து போச்சு அப்படின்னு எல்லாரும் பிரச்சனை பண்ணுறாங்க. ஸோ இந்த மாதிரி இண்டிகேஷனில் நமக்கு we have to safeguard ourselves. இன்டிமேஷன் கொடுத்துறது you will be safer. Because anything happenna proper litigation.
Sir, initially we were giving, sir. Now they are not accepting.
Not
police
needed.
People refusing
If
to take
give,
the intimation.
If they are refusing, no problem at all. Because for the safeguard, to safeguard ourselves, better to give. Let them inquire and whatever they want. Okay. Nowadays, DGP is given notification. If you suspect, you send otherwise. But better for the safe practice, give intimation. Whether they are accepting or not accepting, none of our problem. We should be safe. Because that incidents happen. So all the thing, it's very, very important. Okay, suddenly litigation will come to us. Because of our negligence, patient expired like that. So intimation proper கொடுத்துட்டோம்னா we will be safer. Okay, thank you. Yeah. Will all the venom injected by the snake circulate in the blood? So question is, will all the venom injected by the snake? கடிச்சவனே ஒன்று அதே இடத்துல இருக்கலாம், cellulitis it will produce. Then lymphatic drainage மூலமா it will go to the lymph node, inguinal lymph node, or கையில் எங்கே இருந்தாலும் lymph node and lymphatic circulation, then systemic circulation. So எல்லாமே it will inject to the circulation போகுமா அப்படிங்கிறது தான் question. So it is not true. சம்டைம்ஸ் லோக்கல் செல்லுலைட்டிஸ் மட்டும் இருக்கும். தென் வந்து லோக்கல் செல்லுலைட்டிஸ் மட்டும் ப்ரோட்டீன் பவுண்டாக இருக்கும். ஸோ ஸ்லோவாக இட் வில் ரிலீஸ். எப்படி ஓலியன்டென்சியில் ஸ்டொமக் வாஸ் 3 days கொடுக்கணும், உள்ள ஸ்டொமக்லேயே இருந்துகிட்ருக்கும், ஃபேட்டில் டெபாசிட் ஆகிருக்கும், அப்புறம் டிலேடாக கொஞ்சம் கொஞ்சமாக ரிலீஸ் ஆகி கார்டியோடாக்சிஸ் சடன் டெத் 2nd day 3rd day கேன் அக்கர். ஒடுகந்தலை பாய்சன் 3rd day கேன் அக்கர். அந்த மாதிரி ஸ்னேக் பைட்லேயும் டிலேட் என்வினமேஷன், ஏன்னா ப்ரோட்டீன் பவுண்ட். So some of the venom will be in the cell itself, that's a particular tissue itself. அப்புறம் 70% it will be circulating in the blood, the lymphatic circulation enter into the blood. And the 70% complete it will not, it cause various reactions. But அதுலேயும் protein bound, some of the 40% may be in the protein bound. So protein bound only will cause delayed acute kidney injury. So immediate ASV is a very, very important thing. Protein bound rate to reduce early envenomation is very important. So all venom may not be in the systemic circulation. So systemic circulation, if it is there, 20 WBC will be elevated and positive, or PT-INR will be, PT-APTT will be elevated. So that's very, very important. You have to keep it in mind. So various criteria are there to give ASV. So how much it will be circulating, how much protein bound, everything, Senthil will explain.
Actually, the question put behind this is to tell you that act fast. So the only message from this question is you have to act fast. Okay. So whenever the injected venom is, you have to remember that snake bite is just like an intramuscular injection. Okay. It travels through the lymphatic system. So once the venom is injected, this will enter into the systemic circulation through your lymphatic system. What ASV we are giving is only neutralizing free circulating venom. It is not going to neutralize the protein bounded. So once immediately injected, 40% will get protein bound in the localized area, and the remaining 60 to 70% will be in the circulating thing. So as early as we are able to neutralize with the ASV, then it means that we are reducing the venom load. If we are delaying, or the patient is delaying, going to the native practitioners, and then later they are landing to us, so almost 40 to 50% of free circulating venom will again get protein bounded. So this protein bounded complex will cause all the complications. So even when you are putting a ASV later, so this will not help you out. So you have to treat the patient as early as possible with ASV.
Dr. John Christopher sir rightly asked, first day 20 ella negative, second day வந்து 20 positive. So because of protein bound in the local cell and circulating ASV, that's a venom also, 40% is protein bound, 20 to 30% will be free bound, freely it is available. So that will cause a rise in the APTT and the INR, and 20 WBC will be positive. Later on, the protein bound will be released, that causes the elevation of the PT-INR. So you have to that is a hourly 20 WBCT or PT-INR, and 6th hourly, then 12th hourly, like that you have to do. So any unknown bite or suspected snake bite, 24 to 48 hours observation is the must. When to give, when not to give, because we are in the litigation era. So second day also it may be positive. Ena protein bound lende release aanatha it will be elevated. So local protein bound will be 40%, circulating AM, that's a venom also 40% will be protein bound. Free venom only he can neutralize. That only give the lab investigation will be elevated. So very carefully you have to give. So early envenomation only can neutralize the freely circulating venom. So that should be neutralized. If you don't properly neutralize that free ASV early, it will end up in acute kidney injury. That's a very important problem.
How many of you are experienced in seeing a delayed envenomation? 1, 2. When you have seen that? Any idea? Which month? Not all the time the delayed envenomation will be seen. So again, delayed envenomation, as sir asked, 2 things, sir. This is an ideal time. It starts in the June and it goes up to September, you will see a delayed envenomation. Again, the second peak will start from the March and to May, you will see a second peak. These are the two times they go for breeding. So whenever the snake is going for breeding, you can see a delayed complication, one. Second thing is, if the snake has taken some food, okay, or prey has been taken and then got encountered with the human, then when the snake is bite, you will have this kind of delayed envenomation. If you ask the patient, they would have bit the snake, they would have killed the snake. When we do a dissection of the snake which has been brought, we have seen many times a frog, rat or any other small creature will be inside. All that patients are more prone to develop delayed envenomation. So we have seen up to 96 hours the delayed envenomation. First 2 days it will be totally normal. The patient will tell, sir, ஒண்ணுமே இல்லை, வீட்டுக்கு அனுப்புங்க, நான் போகிறேன் அப்படிமா. சரி அப்படின்னு அனுப்பிச்சி விடுவோம். Third day or fourth day, the patient will again present to us with epistaxis or hematuria or some gum bleeding. Gum bleeding is the first sign. So anything can happen. So you need to be very cautious in sending the patient with delayed envenomation. Again, it is, as it is geographically unique, it is also seasonally unique. And as we are having an opportunity to see farm snake as well as forest snake. So I am in the foothill of Satyamangalam Forest, Western Ghat. We used to see lot of patients from the forest. They don't have any fertilizer, no polluted. So the venom will produces all nonsense things, especially the Russell's viper. They produces lot of complications. We have seen a splenic rupture. We have seen frank hematoma in the liver. We have seen rectus sheath hematoma, ovarian vein thrombosis, peripheral thrombosis. We have seen the bite site going for pseudoaneurysm. Like that, lot of complications. All the snakes are especially from the forest. We need to be very cautious where you are working. That is again an important thing.
So delayed envenomation is,
Next slide.
it's actually June to September and March to March, no?
Sir, March to May.
March to May. Delayed envenomation is very common. So safer side, any unknown bite, 24 to 48 hours observation is must. But when you are sending, at your risk. Delayed envenomation is possible even after 96 hours. Like that, you get a concern and send the patient. Okay, you should not be in the litigation. And next.
Sir? Yes, sir.
So delayed envenomation with the respiratory paralysis. There is no cellulitis. Locus cellulitis is not. Only he had a bite marks in the leg. So second day, suddenly he presented with respiratory paralysis and ptosis.
Usually 6 to 12 hours, sometimes 24 hours also. Many times you have to neck holding, இதெல்லாமே இருக்கான்னு பார்த்துட்டே இருக்கணும் when you, the patient is in the ICU.
Ptosis is the first sign. Okay, if you see ptosis, then there is a chance that the patient may go for respiratory arrest. Okay, and the ptosis is the last sign to recover. First sign to appear and last sign to recover.
And one patient with just ptosis, but the SPO is 100%, everything is normal. Patient was on safer side NIV support. Within 3 hours, patient went for respiratory paralysis. Suddenly, immediately we intubated, saved the patient. Cried bite. So rightly, Senthil has pointed out, ptosis is an early sign. And indications for intubation is very, very important. Early intubation, early extubation, early tracheostomy, all the thing is a game changer in the management of snake bite. Early dialysis, early plasmapheresis, all the thing terminology is a game changers in the to reduce the morbidity and mortality of snake bite. But when to do, when not to do, it's very, very important. So next question is, what are the major disadvantages in performing 20 WBCT for Indian big 4 species? So here, only that is Russell viper, saw-scaled viper, kite and cobra. The 4 தான் ASV, polyvalent ASV will be there. So here 20 WBCT le advantage வந்து across any place, PHC, OP பார்க்குறவங்க எங்கே வேணாலும் you can see 20 WBCT. The problem is 20 minutes you have to wait. 20 minutes wait பண்ணோம்னா further especially neurological complication spread will be very fast. And viper bite, viperla Russell and saw-scaled viperla இதெல்லாம். Then important thing is the bottle எடுப்பாங்க, ஏதாவது நம்ம வந்து injectable bottle அதெல்லாமே. So ப்ராப்பராக test tube should be used properly. ஒரு தடவை யூஸ் பண்ணால் you have to discard it திரும்பி பார்க்கும் பொழுது. So disadvantage is very, very common. But it's easy to use, but disadvantage, lot of disadvantage is also there. But gold standard where you are working, it's very important. So message very important. PT, APTT and INR is very, very important to diagnose whether such an envenomation is there or not. So it's easy to do that. All nurses can do, but proper and the method you can do. But 20 minutes only wait பண்றது அப்படிங்கிறது it's a big $1 million of question. But all labs may not have PTINR. அது இல்லைன்னா இதுதான் வேற வழி இல்லை. But proper method you have to follow. That's very, very important. Sendil, you can add, Sendil.
How you do 20 most?
Take 2 ml of blood, don't disturb it for 20 minutes, keep it in some other test tube or glass container.
So the test tube, still WHO advice 20 minutes whole blood time. Okay, it is very difficult to get a test tube, especially even in a private hospital. It is very difficult to get a test tube. So what we will do is either ceftriaxone or ampicillin bottle. We get it, wash it. That doesn't give you a full state, because if the remnant of antibiotic, especially the ampicillin, that reduces the clotting time. Okay. So even if it is a clotting, it is a over bleeding, it is more than 30 or 40 minutes only we are getting. Otherwise it is very difficult. Even 20 minutes we are missing out. Okay. Using a plastic container, again because of the electromagnetic changes, it will not produce. Okay. It is giving a false. So ideally we have to use the test tube. Test tube we have to take it, and we cannot put it in a direct way. You have to put it in a slide. Okay. Side slide you have to put it. So this will go and settle in one corner, and it should be kept it in the slanting of 45-degree angle. Okay, it should not be kept like this 90 degree. It should be kept in a 45 degree, and we have to check 20 minutes. You should not disturb anything. After 20 minutes is over, then you can try to do it. There is a chance partially clotted and partially it will be diluted. Then you have to wait for another 10 minutes, and then you have to do it. Otherwise the clot will not be ideally there. Okay.
Main thing வந்து அடிக்கடி 5 நிமிஷத்துக்கு ஒருக்க டில்ட் பண்ணிட்டே இருக்குது. 45 டிகிரில you have to keep, and 20 minutes கழிச்சு தான் பண்ணணும். அதில் if it is for 50% clotனா டவுட் இருந்துச்சுன்னா another 10 minutes you wait. That's the thing. Proper method is very important. காமனாக நர்ஸ்ட்டை சொல்லிட்டு போவீங்க, ஆட்டி பார்த்துட்டு இருப்பாங்க. கிளாட் ஆனது கூட என்ன ஆகும்?
டிஸ்டர்ப்
ஆகும்.
Okay. Another one. How frequently you do bleeding time in a snake bite? 6th hourly you do. Clotting time or bleeding time? Clotting time. இப்பெல்லாம் பண்ணுறது இல்லையா? பிடிசிடி பார்க்கணும்னு எழுதுவோம். Only CT you are doing. Bleeding time is not doing. Then very good. Actually bleeding time has no role in snake bite. Okay. So the snake envenomation is just like using in your extrinsic pathway. In a coagulation cascade, it is in a extrinsic pathway and has no role for bleeding time. Only clotting time is mandatory. Don't do bleeding time. Okay.
Yeah, CT only.
Next slide.
All necessary is CT only. 20 WBCT or CT alone. Syndrome approach when snake is not identified. So not identified, there are 5 syndromes. Nowadays syndromic approach. ஏன்னா எல்லாமே வந்து என்ன பண்ணாங்கன்றாங்க, பாம்பை அடித்து you cannot kill the snake, you should not bring the snake, இதெல்லாமே litigation will be there. So syndromic approach, 5 important syndrome இருந்துச்சுன்னா you have to give envenom. That's an ASV, indication for giving the ASV. So important thing, very, very common is Russell Viper. So that is ascending cellulitis with lymphadenitis and presence of CT elevated or 20 WBC elevated, PT, APTT elevated, giving. So this type of picture is Russell Viper. And one type of Russell Viper, some of the months it may present with associated ophthalmoparesis also may be there. And saw-scaled viper, you can see only cellulitis and CT will be elevated. And third thing is actually cried bite. Cried bite mainly neurological manifestation, ophthalmic paralysis, respiratory paralysis. And fourth will be cobra bite. Here also only that's ophthalmic paralysis, respiratory paralysis will be there. And cobra bite, you may present with cardiotoxicity also. Acute coronary syndrome, because of ASV also may present with sudden vasospasm, hypotension they may present. And actually pit viper actually ASV will not work. And CS, that is big sea snake also ASV may not work, only 10% will work. This type of only cellulitis, all the thing will be there, ASV may not work. Severe cellulitis, only myoglobin release and acute kidney injury presentation may be there. So 5 syndrome will be there. These 5 syndrome and cried bite usually they may present with small cellulitis, abdominal colic, vomiting, high BP, dilated people. It's an indication for giving ASV. After a few hours only the patient will present with bulbar palsy, respiratory paralysis. So 5 important syndrome will be there. These are all the important syndrome you have to give ASV. Yeah, you can add a Sandil.
How many of you are still asking the patient to ask which snake has bitten you? Recently, 3 days back, I had a headmaster who was walking in his farm, had a snake bite. Okay, he brought to our hospital. 6 of his relatives were all carrying a yellow color bag. Okay, I asked, what are this? They told, snakes, sir. He told only 1 snake has bitten him, but they brought 6 snakes. Okay, that area, whichever area there is a snake, every snake was being killed and brought. Unfortunately, all 6 are non-venomous. Okay, but the patient was having a clinical envenomation, ascending swelling, blisters, everything was there. Okay, so this snake is not been there. Another one, as per Wildlife Protection Act, if you are asking to bring the snake, or if you are storing the snake in your hospital with a formalin to show the patient, it is an offense. Recently there is a person, I don't want to put his name as it is recording, he is a snake bite specialist in Maharashtra, has been arrested for keeping a dead snake in his clinic. Okay, so don't encourage that kind of practice. If they are brought, ask them to dispose properly, otherwise you collect it and give it to your biomedical waste collector. So don't encourage this kind of practice. WHO has clearly given, we are having only polyvalent. Okay, what snake may be there? It may be a cobra, it may be a Russell viper, or it may be a scarcel viper. Are we changing any ASV? No. I trained in Australia where we have a special kit, single monovalent ASV will be available. We examine, we get the blood sample, we put a ELISA, we confirm it, and then we give. 1 or 2 vials we give. Okay. It is not that 20 vials, 30 vials, what we are giving is not required, that kind of thing. Okay. So always go and treat the patient according to the syndrome, not based on the snake. That is the message. Thank you. Next slide.
Yeah. ASV protocol for dosages.
One நிமிஷம் sir. அவங்களை கேட்போம். What are the ASV protocols you follow?
Yeah, quickly, if you ask questions, it will be a rapid fire question answer.
We will answer more.
More questions, okay. Don't hesitate to ask even a chilly questions. Okay.
தமிழ்நாடு கவர்மெண்ட் கைட்லைன்ஸ் தமிழ்நாடு கவர்மெண்ட் கைட்லைன்ஸ்
என்ன அது நான் எழுதுனேன் சொல்லுங்க.
Yeah, quickly.
சார் ஃபஸ்ட்டு 8 vials of ASV to be started. After that 6 hours whole blood clotting time to be seen.
Any difference from him? You will start 8 vials and wait for 6 hours and then you will continue.
Repeat
Repeat.
or not repeat. Any other
guidelines?
Tell me. Yeah, loud.
Any other protocol
Be
you
louder.
follow?
Give some mics. ASV is very important question.
Sir, usually we break 1 vial and mix it with 100 ml NS and give it over 15 minutes to check for anaphylactic reaction. And after that, we'll give another 9 vials. So if there is no anaphylactic reaction, we'll give every 6 hourly 10 vials.
Okay. if the patient is having anaphylactic reaction, whether it is a contraindication to give ASV, you have to desensitize and again you have to give.
Actually, this is a wrong protocol and it will delays the treatment. Okay, so this practice should be withdrawn. As per the WHO and as well as Tamil Nadu government, initially we designed it as this brother told, it was 8 vials, and I was a part of guideline committee. Initially they advised to start 8. Now it has been changed to 10 vials. Okay, so for a safer side, we put 8 to 10 vials as a first hit. Okay, ASV does not need any test dose. Why? Though it is a foreign body, we don't have any other alternative. Okay, so we have to give ASV. There are certain situations where without ASV we treat. That is entirely different. So 8 to 10 vials is initial dose. We give over 45 minutes. Okay, and there are 2 schools of thought here. One school, they will wait for 15 minutes and then they will give another 10 more vials. Another school, they don't give immediately. They will wait for 6 hours. They will allow the liver to regenerate for the clotting parameters and then they give. Okay, again it depends upon which institution you are working. In our institution, what we do is we give 10 vials, we wait for 6 hours, then we do clotting time or prothrombin time, INR, and then we continue it. Okay, that is reducing the ASV scarcity. At the same time, the safe limit is given. And a few centers, few premier institute, what they follow is 45 minutes, they will give 15 minutes a drug-free period, and then they will start another 10 vials. In CMC Vellore, initially they had 2 protocols. One, they used to give low dose. They will give only 4 vials, and then 1 vial every hour they will infuse, continuous infusion they used to give. Now they found it is not much helpful. They all withdraw that protocol. So now the standard protocol is for any bleeding manifestation, maximum 25 to 30 vials. For a neuro snake bite, neurotoxic, 10 vials was initial, another 10 vials was given. Now it is changed to single dose of 20 vials. Okay, so that we can reduce the ventilatory support.
So because of scarcity only they are telling. So neuroenvenomation, if you are suspecting, 20 vials, statum slowly over 1 hour, not slowly, over 1 hour. And other viper bite, Russell or crate bite, first 10 vials over 45 minutes, then 15 minutes interval. After that do CT or PT-INR or 20 WB CT. If it is positive, restart and give 45 minutes and again wait for 15 minutes. Again you do that. So first 10 vials, after 1 hour, next 10 vials. After the second hours is over, 5 to 10 vials depends upon your clinical features. So maximum 30 vials are more than enough. Neurological envenomation, 20 statum, not 10 plus 10, 20. Okay. If the patient getting neurological deficit or ventilator support, if required, immediately put them on intubate, and early intubation is very, very important. So minimum this is 10 vials, maximum 25 to 45 vials, 30 vials, maximum 30 vials. This is the standard protocol. So you need not wait for 6 hours. Car it's not a criteria. So you have to give infuse. So hit hard, hit fast rule should be applicable, and as a complete physician, critical care physician, treat as quickly as possible. And all the treating physician, whether you are treating in the PHC or in the clinic or the multi-specialty hospital, you should know how to treat the ASV-induced reaction. There's any reaction or pseudo reaction, give off cc of adrenaline in the over the lateral aspect of the thigh. That's we will come to a later. So immediately give. So usually first aid பண்ணிட்டு அனுப்புறேன் செய்யணும் அப்படின்னு வேஸ்ட் பண்ணாதீங்க. If you are confident enough to, because ASV reaction also may kill the patient. Litigation வரும். If you are confident enough to do that proper, இது இருந்துச்சு அப்படின்னா ரெக்கார்ட் பண்ணிட்டேன்னா there won't be any problem. Because anaphylactic reaction இருந்துச்சுன்னா immediately give off cc of adrenaline over the lateral aspect of the thigh and refer the patient to the where ventilator care everything is available. Yes, sir.
The WHO guidelines for a SAS scale like 5 is enough, no?
Latest SAS scaled viper they are removed from Big 4. They say that it is not producing any harm, but in western area, okay, SAS scaled viper producing lot of complications. So still they are using 10 vials as a stat, and then they are continuing it. But WHO, they say that 5 to 10 vials is sufficient for saw-scaled viper. But again, it is geographically dependent. In Assam area, Russell viper is mostly innocuous. Himalayan pit viper and saw-scaled viper, Ichnus scotus, producing more nasty complication. Whereas in south, Russell viper produces more complications.
Then saw-scaled viper.
Saw-scaled is almost here, not much no, sir.
It's there. எங்களுதுலாம் இருக்கு.
இல்லை இருக்கு சார், பட் காம்ப்ளிகேஷன்ஸ் நான் சொல்கிறேன், வெரி வெரி லெஸ்.
But safer side 10 vials is better.
5 to 10 vials,
சொன்னால்
sir.
5 to
5
10.
to 10 vials.
Depends upon the clinical pressure. You take up a decision. But WHO is universal for the world. But in South India, actually
There
5
is
to 10.
local, only local envenomation. There is no evidence for any systemic envenomization. But usually we used to advise our PG interns 10 vials, and if there is a spreading cellulitis, continue for 30 vials. Is it okay, or we have to change?
Spreading
Actually, it
cellulitis.
is, spreading cellulitis is advised,
definitely.
sir, definitely. But local cellulitis, we don't advise. When I was doing my internship, my professor used to say, whenever there is a local cellulitis, daily 5 vials. Until the cellulitis disappear, we have to give 5 vials. Give 5 vials daily. It may be 3 days or it may be 7 days, even 10 days we have given, 50 vials and all we have given only for local cellulitis, then later turn to be any other insect bite or any other thing. So local cellulitis is not an indication for ASP. Yes, sir. Bite mark with the local cellulitis without any systemic manifestation, no need, sir. No need.
Ascending cellulitis.
Ascending, yes, definitely we have to
But
give.
lymphadenitis. If there is a lymphadenitis, you have to-
Lymphadenitis, tender lymph nodes, then we have to
Definitely.
give, sir.
Small
Or-
cellulitis
yes, sir.
without lymph.
Sir? 10, sir. 10 is sufficient. 10 is sufficient.
So ASVs, you have to be, it's very clear, no? So 10, 10, 5 to 10. So maximum 30. Here, Crite and Cobra, maximum 20, Statum. That's all. And ptosis is the earliest manifestation, late manifestation will disappear. So ptosis வந்தாலே you have to be ventilator support எல்லாம் ரெடியாக வச்சுக்கணும். இமீடியட்டாக இன்டிபேட் பண்ணுறதுக்கு you have to be prepared. Sometimes anesthetist வேணும்னா இல்லை if you able to do the intubation, immediately do the intubation.
Symptom, first symptom of poisonous snake bite, I observed few cases. Anybody? So altered taste sensation, that is the best, earliest thing they get after a poisonous snake bite. I observed almost over 20 cases we observed, gave some bitter thing, they swallowed. But non-poisonous snake, we give this better thing, they vomit.
Sir, actually, it is in
Earliest-
Siddha medicine. It is in the Siddha medicine. Actually, from Tirunelveli, one Siddha scholar came and did a study in our thing. It is called Aadu Thodathalai. Therima? Even the goat will not eat that leaf. It will be very, very bitter. Okay? So there is one Siddha Padal, Tamil song, in that they have classified that Russell viper, okay, that will produce sweet taste when they bite the Aadu Thodathalai, okay, within 1 hour. I'm not here to promote other speciality, just to add this, okay. And this is scientifically they have proven. And we have seen the snake, it is totally blinded, and the scholar will come, they will ask to eat, and the patient will tell, sir, it is sweet. That means he will write as Russell viper. If it is salty, it is saw-scaled viper. If it is bitter, okay, and they will spit like anything, and they will shout us, why you are giving this to eat, okay. It is very, very bitter. I have tasted, it is very bitter. So it is a non-venomous thing. And if it is sore, okay, it is cobra, okay. And light, one silky like sensation in the mouth that comes by the crite, okay. They have differentiated and we have clearly seen, and this also be given as a part of PhD under MGR University, and he has got the PhD in the snake bite using this Aadu Thodathalai, okay. So altered taste sense is very, very important, and we have also published a case that the patient developing loss of taste, ageusia is very, very common if the patient goes for the Russell's viper, and they will try to shout. Okay. At the same time, the color blindness is also common. So you need to be very cautious in especially treating with oleander poisoning and as well as snake bite. The color blindness is very, very common because this component will go and attack the retinal cells. Okay, be there.
அப்புறம் நாய்க்கரெல்லாம் அனுப்பிச்சி விடுவாங்க, மிளகாயை உள்ளே போடுவாங்க, காரமே தெரியலன்னா உடனே அதான் ஆல்டர்ட் டேஸ்ட். காரமே தெரியலன்னா இம்மீடியட்டாக நாய்க்கர் எல்லாமே அதை உடனே ரெஃபர் பண்ணுவாங்க. தே வில் ரெஃபர் டு த டாக்டர். ஓகே, மிளகா போட்டோடனே காரமே தெரியல, இம்மீடியட்டாக டாக்டர் போய் பார்த்துக்கோ, இல்லாட்டி ஏதோ நாட்டு வைத்தியம் வந்து அமைச்சிருப்பாங்க. இதுவும் ஒன் ஆஃப் த வே. ஸோ ஆல்டர்ட் டேஸ்ட் ஆல்சோ யூ ஹாவ் டு கீப் இட் இன் மைண்ட். ஓகே, லைக் கோவிட்டில் ஆல்டர்ட் டேஸ்ட்லாம் இருந்துச்சு இல்லையா, அது மாதிரி இதுலேயும் யூ ஹாவ் டு கீப் இட் இன் மைண்ட். ரைட்லி பாயிண்ட் அவுட் பை செந்தில், ஏன்னா ரிசர்ச் பப்ளிஷ்ட் இந்த இது ரிசர்ச் ஸ்டடி. ஸோ வேரியஸ் டேஸ்ட்டு, பிட்டர் டேஸ்ட்டு, இல்லை ஆல்டர்ட் டேஸ்ட்டு, ஸ்வீட் டேஸ்ட்டு, ஸோ சோர் டேஸ்ட், இந்த மாதிரிலாம்.
What are the disadvantages you have faced with polyvalent?
Anaphylactic reaction, sir.
Other than that, any polyvalent, any reaction? No? Acute kidney injury. Okay. Any other?
So here question is major advantages and disadvantages in using polyvalent. Advantage definitely India it's a polyvalent because major 4 species, big 4 species it will cover. But Sri Lanka, Australia single ada kit போட்டு இந்த bite அப்படிம்பாங்க. So particularly 1 vial 3 vials அதை you can restrict the ASV. Here polyvalent, நம்ம இந்தியா ஃபுல்லாக polyvalent தான். But disadvantages நிறைய, there are a lot of disadvantages, reactions are there, but I have discussed with Sendil. In my hospital there are a lot of reactions for the ASV. But he has rightly pointed out, hand hygiene is very, very important. The powdered form, then mix பண்றப்ப you are powdered form or liquid form ரெண்டும் available previously. இப்போ liquid form it is available. Hand hygiene is very, very important to reduce the anaphylactoid reaction or anaphylactic reaction. So hand hygiene is very, very important. So you have to teach properly while taking the distilled water and mixing, the hand hygiene is very, very important. If you do proper hand hygiene, definitely in his center actually less than 10%. That's anaphylactic reactions. So anaphylactic reaction la neriya patient they died. So you have to be very careful. Many patients recently actually one patient actually iron injection for the pregnant lady, immediately anaphylactic reaction, they have not given only aviltecatran, F-carlin எல்லாம். Immediately lateral aspect of cc of adrenaline will save the patient. Shock full of position, I have to do direct IV adrenaline unless it's contraindicated. And immediate பண்ணாதனால lot of complication and ECMO எல்லாம் போய் patient revived. So all the physician you should know anaphylactic reaction, don't hesitate to give off cc of adrenaline. Whether adrenaline or atropine பார்த்துட்டு ப்ராப்பராக டாக்குமெண்ட்டோட immediately give. All the patient wherever injection போடுறாங்க எமர்ஜென்சியில் adrenaline knowledge while always you should have. Many patients in my 25 years practice we have lost because of anaphylactic reaction, improper, immediate கொடுக்காதனால patient we could not able to survive actually. So immediately I have to give. So in my center more than 40% anaphylactic reaction. So you should give. So important thing is off cc of adrenaline over the lateral aspect of the thigh. That's very, very immediate கொடுங்க. 2 ml syringe load பண்ணு, இல்லை insulin syringe ஓட. It's IM injection. போட்டிங்கன்னா there won't be any problem, patient will recover. Mortality வராது. Yeah, you can add Sendil.
In our hospital every day, when the staff nurse entered into the emergency room, they will break the adrenaline, it will be loaded in the syringe and it will be put as a date. Okay, so we don't want to search the time the adrenaline when the anaphylaxis is going on and breaking and then loading it.
Each and every second microsecond is
only
important.
It cost only 2 rupees. Okay, even 30 days we are not using also, we are going to lose only 60 rupees. But one chance, if we are delaying, immediately it will go for cardiac arrest. So to prevent that, it is a routine practice we do in our emergency room. Daily the adrenaline will be loaded in a syringe and next day till 24 hours it's a half-life in that. Okay, After 24 hours, we will discard it and we will take another adrenaline. It is not going to cost much when you compare to the life of a patient. Okay, anaphylaxis kills. It will entirely spoil your reputation. Single case is enough to spoil your reputation. And ASV anaphylaxis is nothing, mostly anaphylactoid reaction, mainly like pyrexia, chills, rashes. Everything can be reduced by doing a proper hand hygiene. Okay.
அது மெயினாக வந்து காதெல்லாம் அப்படியே காது அரிக்குதும்பாங்க.
First sign is the ear swelling and ear warmth. Okay, the patient will tell you, sir, something is going hot, warmth over the ear. If you touch, you can see the pinna is swollen. That is the first sign. Before
Then
any
difficulty
rash,
in-
anything.
After that, difficulty in breathing, palpitation. So இம்மீடியட்டாக இன்ஜெக்ஷன் கொடுத்துட்டேன்னா, ஸோ த ரூல் வந்து நாளைக்கு ப்ராக்டிஸ் பண்ணும்பொழுது இன்ஜெக்ஷன் ரூமு, கேஷுவாலிட்டி ரூமு, லேபர் வார்டு, ஓடி, ஐசியூ எல்லா இடத்துலையும் டெய்லியும் ரொட்டீனாக நர்ஸ் வந்து ஒன் ஆம்பிள் லோட் பண்ணி வச்சுருக்கணும் டேட்டு டைமோட. திஸ் ஷுட் த கேரி ஹோம் மெசேஜ் ஃபார் யூ டு சேவ் லாட் ஆஃப் பேஷன்ஸ் இன் ஆல் ஹாஸ்பிட்டல் ஆர் கிளினிக் எவ்ரிவேர். ரொட்டீன்லி லோட் பண்ணி டேட் போட்டு வச்சுருங்க. ஏன்னா வித்தின் ஃப்ராக்ஷன் ஆஃப் செகண்ட்ஸ் யூ மே லூஸ். ஸோ இம்மீடியட்டாக தொலைவிட்டு இருக்கிறது இங்கெல்லாம் அங்கெல்லாம் அதெல்லாம் இருக்கக்கூடாது. எமர்ஜென்சி என்ஏபிஹெச் அக்ரிடேஷன் வாங்குற மாதிரி அதை லோட் பண்ணி வச்சுருங்க. இன்ஜெக்ஷன் வைக்கிறது மட்டும் இல்லை, டெய்லி ரொட்டீனாக இட் ஷுட் பி a protocol for your practice. ஓகே, ஸோ அனஃபிலாக்டிக் ரியாக்ஷன், அனஃபிலாக்டைட் ரியாக்ஷன் எதாக இருந்தாலும் adrenaline will save the patient. ஐஎம் தான் சில சமயத்தில் டைரக்ட்
No need to remove the dress and all. Okay.
அப்படியே போட்டுடலாம்.
How many of you are used EpiPen? I don't know. So EpiPen is common in Australia. We advise them whenever we are going for a wilderness or going for a trekking. Now also our people are coming. Sir, நான் இந்த தோகமலை மேகமலை வந்து ட்ரெக்கிங்க்கு போகிறேன், சத்தியமங்கலம் ஃபாரஸ்ட்டில் ட்ரெக்கிங் போகிறேன்னு வந்து கேட்கும் போது வி அட்வைஸ் தம் டு கிவ் எப்பிபென். எப்பிபென் நம்ம இதில் வந்து ரொம்ப காஸ்ட்லி. ஸோ எப்பிபென் இஸ் ஆல்மோஸ்ட் 4,000 rupees and the shell life is only 1 year. அந்த 1 yearல அவங்க யூஸ் பண்ணலன்னா it is going to waste. So we give them a adrenaline. Okay, so just like that it is, no need to remove the dress or anything. Just like that they can inject it on the lateral part of the thigh. At the maximum 3 doses is sufficient.
Maximum 3 dose. 1 dose 90%, no problem. In my practice, on maximum 2. Sendil experience 3 dose maximum. Okay, so if there is a anaphylactic reaction, stop ASV, desensitize. Again, you start with the micro IV set or infusion pump slowly, then slowly update it. When you are giving ASV, sit with the patient. You or duty doctor or eminent staff nurse for first 20 minutes. First 20 minutes is a vital. அந்த டைம் தான் அனஃபிலாக்டிக் ரியாக்ஷன் யூ கேன் கெட் ஆன்டிசிபேட். அந்த 20 minutes தாண்டிடுச்சுன்னா there won't be problem, will not be much. So maximum 3 doses. Single dose is more than enough. So ASV reaction, don't hesitate, don't have a fear at all. But anytime intubate பண்ணுற அளவுக்கு இருக்கணும். ஒன்ஸ் ரியாக்ஷன் இருந்துச்சுன்னா you have to shift the patient where there is a ventilator care எல்லாம் இருக்கிற சென்டர் ஆஃப் பண்ணுறது. It will be safer. Okay, what are the disadvantages in the developing monovalent antivenom? So monovalent இந்தியாவில் we are not at all using. அதில் disadvantage இதில் வந்து மெயின்லி வந்து
So we are talking a lot about the disadvantage of polyvalent. So why don't you come with a monovalent? This was a proposal submitted by our society so to the government, and the government saw the feasibility and asked some vaccine manufacturing institute like Serum Institute, Bharat Serum to design and develop, and now the Premium Institute has come with the monovalent. But the disadvantage is that every patient has to get a kit and to diagnose whether it is a cobra or it is a crite, then we have to identify it and then we have to give. And the cost of the monovalent is much higher than normal polyvalent. So it is not kicking off in our country because of the cost factor and the infrastructure. Every hospital should have a kit. We have to able to differentiate whether this patient is a Russell Viper, crite, cobra, saskale or a non-venomous. Like that we have to differentiate, then we have to give. So it reduces the time and reduces the ASV. It is a good thing, but the cost. Single monovalent ASV is costing around 1,900 rupees. So for a patient, we need 3 or 4, it costs 6,000. Whereas even 30 vials we put here, it is not going to 400 rupees. Okay, so 10 vials, 4,000 rupees, it will over. And the kit cost is 12,000 rupees. So they will not able to buy the it and then we analyze, and then it is very difficult unless we come with a new methodology to do that. So research are going on. So still now it is not going to feasible in our country.
செந்தில் எப்படி ஏஎஸ்வி ஹார்ஸ் 4 பாம்பையும் கடிக்க வச்சு they are
So
preparing.
actually what they will
Where
do
they are
is
preparing?
in ASV, in Musol, they will take a mull, okay? It's a mule, a horse and donkey crossed, they will take and they will growing in their thing. So what they will do is they will inoculate a small amount of Russell Viper, the small amount of crite, they will inject cobra, and then they will collect the blood and they will form the antibody, they will purify it and they will come. So each polyvalent will contain 0.6 milligram of Russell, 0.6 milligram of your saw-scaled viper, 0.4 of cobra and 0.4 of crite. Okay, this is the thing. So each vial will neutralize 0.63 will be there. So roughly 600 milligram will be neutralized with a single vial. Okay.
எங்க they are preparing in
So
India?
it is provided in Himachal Pradesh. Okay. Now the reason is even Sri Lanka, Maldives, Lakshadweep, all getting ASV from our country only. This is not working. Okay, it is not working as expected. So even the ASV which is produced in the Himachal is not working in our place. It is geographically unique. So with the IIT Bangalore, they have differentiated this, and now we have formed 5 manufacturing unit across the country. One is central, that will take care of western area and the central area of the country. South, they have started in Bangalore. Another one is in Assam, another one is in Bombay, and one is in Himachal. So they are taking now the venom, only they have been collected from the particular geographical region. Before that, it is an offense that anybody can get. Only in our country, Irla Society is been authorized to collect the venom, and the company has to buy from the venom from the Irla group of people only. It is there in Madras Crocodile Park, where they will extract the venom and they will give you. If you want to do some kind of research work, animal study, you want to work, we can apply it and we can get it. Okay. So the company is also getting that from the Irla Society only. Now they are formulated in a different area, and then 5 manufacturing units have been there. So now the production is started, and the venom quality is also, ASV is also improving.
Previously scarcity was there. இப்போ ஏஎஸ்வி இல்லைன்னா என்ன பண்ணுறது அப்படின்னா ரசல் வைப்பர், சாஸ்கேல் வைப்பரில் பிளாஸ்மா பாரிஸ் இஸ் த ஒன்லி திங். கிரைட் பைட் அண்ட் கோப்ரா பைட் வென்டிலேஷன், வென்டிலேட்டரி சப்போர்ட். ASV is not available. And that's Russell Viper, saw-scale Viper, you can give FFP also when there is a scarcity. That is the only thing. So this is all the thing. So ASV nowadays scarcity is not there. It's freely available in the government as well as in the private. So that's very important. What are the major issues in using tourniquet following snake bites? Following snake bites. It's very important, major issue. Tourniquet, tight கட்டிட்டோம்னா definitely necrosis will occur. அதில் 2 fingers, because ஓவர் டைட்டாக பண்ணிங்கன்னா நாட் ஒன்லி லிம்ஃபேட்டிக் ட்ரைனேஜ், 2 fingers உள்ள வர்ற அளவுக்கு தான் கட்டணும். ஏன்னா when there is a snake bite, it is like a fracture. Fracture patient ஓட சொல்லுவீங்களா, நடக்க சொல்லுவீங்களா? Never. It's like a IM injection. போட்டு தள்ளிடுச்சு, IM இன்ஜெக்ஷன் இருக்குது. ஸோ டர்னிக்கு வந்து டைட்டாக கட்ட வேணாம், 2 விரல் இது பண்ணுற அளவுக்கு you have to. And as early as possible, you have to transport to the hospital, concerned hospital. So fracture management மாதிரி just immobilization is very 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 important. Then டைட்டாக அது பண்ணிங்கன்னா ஆர்ட்ரி வெயின் ரெண்டையும் கம்ப்ரெஸ் பண்ணுது. ஸோ எடிமா, தென் எடிமா, ஸோ நெக்ரோசிஸ், கேங்க்ரின் சான்சஸ் ஆர் வெரி ஹை. ஸோ டர்னிக்கில் மெயினாக துணி இருந்தால் போதும். மெயினாக கயிறை வச்சு கட்டுறேன், அதை கட்டுறேன், கடித்து எடுக்கிறேன், விஷத்தை எடுக்கிறேன், இதெல்லாமே மால் ப்ராக்டிஸ். பிகாஸ் எடுக்கவே முடியாது. ஒரு இன்ஜெக்ஷன் நீங்கள் ஐஎம் போட்டதுக்கப்புறம் உடனே கடித்து எடுக்க முடியுமா? பிகாஸ் ஐஎம் இன்ஜெக்ஷன். ஸோ கடித்து எடுக்கிறது, இந்த மால் ப்ராக்டிஸ் எல்லாம் பிளேடில் கிழிச்சு விடுறது, இட் வில் நாட், பிகாஸ் லிம்ஃபேட்டிக் சிஸ்டம்லாம் ஆல்ரெடி இட் வில் கோ அசெண்டிங் போயிட்டே இருக்கும். ஸோ டர்னிக் அப்ளிகேஷன் வெரி வெரி காசியஸ் இஃப் நீடட். பிகாஸ் இந்த டெக்னிக் ப்ராப்பராக தெரிஞ்சால் டர்னிக்கு கட்டுங்க, இல்லாட்டி வேணாம். பெட்டர் சிஃப்ட் தம் அஸ் ஏர்லி ஆஸ் பாசிபிள். என்ன வந்தாலும் வி வில் இது பண்ணலாம். அதே சமயத்தில் டைட்டாக டர்னிக் இருந்துச்சுன்னா ரிலீஸ் ஆல்சோ வெரி இம்பார்ட்டன்ட் இந்த மேனேஜ்மெண்ட். வேகமாக ரிலீஸ் பண்ண சடன் சர்ஜ் இன் டு த லிம்ஃபேட்டிக் சிஸ்டம், சடன் என்ட்ரி
ரிலீஸ் இஸ் வெரி இம்பார்ட்டன்ட்.
வெரி இம்பார்ட்டன்ட். திஸ் ஆல் வெரி இம்பார்ட்டன்ட் டிப்ஸ். யூ கேன் ஆட் செந்தில்.
ஸோ மெனி டைம் என்ன பண்ணுவாங்க அப்படின்னா ஒரு கட்டு கட்டுவாங்க, இன்னும் பேஷண்ட் வந்து தே ஆர் வெரி க்ளோஸ், 2 கட்டு கட்டுறது, 3 கட்டு கட்டுறது, மேலே கால் வரல இங்கே வரலும் கட்டியிருப்பான். என்னென்னா இதுலேருந்து தப்பிச்சா இது, இதுலேருந்து தப்பிச்சா இது நிறுத்திக்குது, இதுலேருந்து தப்பிச்சா இது வந்துடுது அப்படின்னு சொல்லிட்டு ஒரு 10-12 கட்டோட வருவாங்க. அது இன்னும் சாமி கயிறெல்லாம் வந்துருச்ச கயிறெல்லாம் கட்டியிருப்பான். சார் அதெல்லாம் கட் பண்ணாதீங்க, அப்படியே பிரிங்கம்மா. ஸோ தட் ப்ரொடியூசஸ் லாட் ஆஃப் வாஸ்குலர் இஸ்கீமியா வில் பி தேர். இஸ்கீமியா எவ்வளோக்கு எவ்வளோ இருக்கோ அங்கே ப்ரோட்டீன் பவுண்ட் ரொம்ப அதிகமாக இருக்கும் ஒன்று. ஸோ லோக்கல் நெக்ரோசிஸ் வில் பி there, skin will be lost, one. Second thing, the patient will start ascending the venom. ஸோ ரிலீஸ் பண்ணுறதுக்கு முன்னாடி என்ன டீச்சிங் இருந்தது அப்படின்னா, we have to inflate it with the tourniquet. Okay, multiple tourniquet வந்து as what we are doing in the theater for a lower limb surgery. We put a multiple tourniquet, pressure tourniquet with a pressure cuff and pneumatic tourniquet. Then slowly we will remove it and then we will release the tourniquet one by one, but it delays lot. So now what we are doing is we put a Venflon, start a lifeline, give a 500 ml of fluid as a bolus, keep adrenaline, at the same time ASV is ready, then you can remove it. Okay, directly, no need for putting a tourniquet and other thing. Very important, when you are removing the tourniquet, if the patient say, I had a sudden blow in the back, that means the patient is having a highest amount of venom load. You need to give maximum dose of ASV as early as possible to neutralize it. Okay, that is a bedside point.
ஸோ வெரி இம்பார்ட்டன்ட், டர்னிக்கு ரிலீஸ் பண்ணுறப்ப ரொம்ப டைட் டர்னிக்கு பண்ணால் ப்ரோட்டீன் பவுண்ட் செல்லிலே இருக்கும். ஸோ டிலேட் என்வெனமேஷன் இஸ் காமன். சடன் பர்ஸ்ட் உள்ள ஃப்ரீ வீனம் இந்த பிளட் சடனாக போகும். ஸோ யூ ஷுட் பி ப்ரிப்பேர்ட் டு கிவ் ஏஎஸ்வி குவிக்லி without any reactions. So release also is very important. So very very cautiously you have to do. And necrosis irunchina bound, protein bound will be high, more prone to develop acute kidney injury, more spreading cellulitis, all the complication. Many patients we are losing our morbidity and mortality is high because of spreading cellulitis, because of acute kidney injury. Rather than giving adequate ASV kuduthum kuda, these are all the problems. Okay, so quickly we'll FFP in snake bite, when and how much? It's very important thing. Fresh frozen plasma. Nowadays, fresh frozen plasma already told. ASV are not available now, you can give. When and how much? Usually, பாம்பு கடிச்சதுன்னா டெஃபினட்டாக ASV is the role. ASV adequately கொடுத்துட்டு then still first 10 vials கொடுத்துட்றோம், 1 hour வெயிட் பண்ணுறோம், CTR PTINR elevated again 10 vials, still elevated again 10 vials, maximum 30 vials. So still it's elevated, he can give FFP. Because definitely that's a coagulating factor will be synthesized in the liver after 6 hours. But if you are having, the patient is having severe bleeding tendency, gum bleeding, upper GI bleed or any bleeding, no other go, 30 vials போட்டதுக்கப்புறம் he can give FFP 4 units. Then 6 hours கழிச்சு you can repeat or not repeat. Usually 4 units of FFP is more than enough. ஏன்னா 6,000 rupees more than enough. But இதுனா 6,000 தானா, எதுக்கு 30 vial போட்டுட்டு இதுக்கு ரீப்ளேஸ் பண்ணலாமா? No, only ASV தான், it's a must. ASV போட்டுட்டு then still consumption coagulation is there, definitely FFP has got a role. Platelet குறையுது, cryopressity இதெல்லாம் இருக்குது அப்படிங்க, அதெல்லாம் there is no role at all. So FFP it has had a role, immediate need not give. Many time அந்த 30 vials முடிச்சதுக்கப்புறம் you give FFP if necessary. Otherwise don't unnecessarily give. You can add something.
Early FFP, sir, mostly 4 vials it will settle, sir.
4 units
4 units is sufficient.
FFP is more than enough. After 30 vials.
So after 30 vials, still you feel that the patient is having an overt bleeding, don't just treat the numbers. Symptomatically the patient is having a bleeding, then we can think of giving FFP. Just having a prolonged INR, the coagulopathy is there, no need. Okay, so you can think why to put a ASV, directly we can go FFB and we can neutralize it. It is just adding a fuel to fire. Okay, if you put FFB without giving ASV, it will produces thrombosis. Okay, it will increases the thrombosis, so the risk of thrombosis is very high. So venom induced coagulopathy, the consumable coagulopathy will be there, more inside of thrombosis will be there. They will develop CVT, they will go for renal vein infarction we have seen. Okay, where the ASV was not there, treated in a peripheral hospital, they have given FFB, and the second day the patient developed abdominal pain, then later referred to us, turned to be infarction in the kidney because of renal vein thrombosis, renal artery thrombosis was there. So give adequate neutralized, 30 vials maximum. Okay, then we can think of FFP.
In my clinical practice, ரசல் வைப்பர் பெரிய பாம்பா கடிச்சிட்டு வந்துட்டாங்கன்னா எஃப்எஃப்பி ரெடியாக வச்சுருங்கன்னு சொல்லணும். 10 vials, next 10 vials, next third hour. Still complication, give 4 vials. In my clinical practice, பெரிய ரசல் வைப்பர் பார்த்தவொடனே half an hourல ஸ்ப்ரெட்டிங் செல்லைட்டிஸ் போயிட்டே இருக்குது அப்படின்னா 30 vials followed by 4 units of FFP. Definitely in my clinical practice, AKI incidence it's less. Even AKI வந்தாலும் மெடிக்கல் மேனேஜ்மெண்ட்லே they come out very well. That's very, very important message I want to give. So the intensity, spreading cell is half an hour கடன்னு மேலே போகுது அப்படின்னா keep ready FFB. 30 vials முடிச்சதுக்கப்புறம் you give if necessary. Don't hesitate not to give, and if you are strong enough, okay, it's போதும் அப்படின்னு நினச்சிட்டிங்கன்னா need not give. 30 vials maximum ASC plus 4 FFP unit. If we give, if it is necessary, definitely in my clinical practice, AKI incidence is low. Even recovery of the AKI, even after dialysis also will be better with this. But rightly pointed out by Dr. Sendil, first FFP போடாதீங்க, first 30 vials ASV கொடுத்துட்டு then if necessary FFP. Previously சுட ரத்தம் போட்டேன் அப்படின்னு சொல்லிட்டு கேரளா இதெல்லாம் வெஸ்ட் பெங்கால்லாம் சொல்லுவாங்க. There is no role. இப்போ எல்லாமே product components only.
In clinical experience, so even after 4 vials of 4 units of FFP, even for another 48-72 hours, bleeding continues. Few cases last month also.
You can go, repeat.
So bleeding continues. So we repeated again. So only after 96 hours only, but soon after a patient developed severe AKI and he needs no urine output and dialysis.
If there is a bleeding, then we can continue. So early morning paralysis and brain dead in snakebite is very important in a crite. As sir rightly pointed out, they would be lying down in the street or open area where there is more chance of getting crite. Crite bite is a nocturnal creature and it likes more on warm. Okay, warmth is increases. So they will enter into your home and they will bite. It is just like a mosquito bite. Okay, you will not feel any local swelling or anything. One important thing is they will have early morning, they will have an abdominal pain, vomiting, and if you do, there will be a hypokalemia will be there. Okay, so most of the time, I have received more than 15 cases of crite bite operated as case of acute appendicitis, later developed respiratory arrest sent to us for ventilatory support, later turned to be snake bite. Okay, so how to differentiate this early morning paralysis is look for a broken neck sign. If there is a broken neck sign, okay, then it is snake bite. If there is no broken neck sign, then you can go and do another thing, ultrasound and other things. But early morning paralysis, they will just mimic like your myasthenia, acute attack of myasthenia. Diplopia will be, dysphonia will be there, dyspnea will be there, dilated pupil will be there. All Ds, killer Ds will be there. So you need to be very cautious in treating, because stamping them as myasthenia, then they have to take for a lifelong, they have to take the medication. I have seen a patient who has a crite bite, diagnosed as myasthenia. Immediately they took the patient for plasmapheresis and they treated. Almost crite also improves with the plasmapheresis without ASV, and then the patient was put on a medication for a long years. Later it turned to be a snake bite. Okay, so be cautious when handling this early morning paralysis.
And a very important point, Dr. Velisamy, senior most physician, டெத் ஆகிடுச்சு எரிக்க போகிறேங்கிற ஸ்டேஜில் போய் இல்லை இது பாம்பு கடி ஏசி போட்டு காப்பாற்றுறேன்னு கொண்டு வந்த பேஷண்ட்ஸ் இருக்கிறாங்க. எரிக்க போகிறதுக்கு முன்னாடி ஹைப்போகிளைசிமியாவில் டெட் மாதிரியே இருப்பாங்க, எல்லா டியும் இருக்கும், கொண்டு வந்து உடனே போட்டு எந்திரிச்சு முழிப்பாங்க. ஸோ கோப்ரா பைட், கிரைட் பைட்டு, ஹைப்போகிளைசிமியா, they will present like dead body. So very careful, immediately pulse பார்த்துட்டு dilate people immediately you have to give ASV or ventilatory support. So broken neck sign is very, very important. Many patient நல்லா தான் இருக்க ஒன்றும் இல்லை அப்படின்னு சொல்லிட்டு போவாங்க, 6 மணி நேரத்தில் broken neck சைனோட வாயில் எச்சியாக வந்துட்டுருக்கு, பேச மாட்டேங்கிறாங்க, நாக்கு நீட்ட மாட்டேங்கிறாங்க அப்படின்னு சொல்லிட்டு கொண்டு வருவாங்க ஏர்லி மார்னிங். கரெக்டாக ஏர்லி மார்னிங் 12-1 மணிக்குனா அன்லெஸ் ப்ரூவ்ட் அதர்வைஸ் a crite bite. So always observation. If the patient is hesitant, immediately observe பண்ணிக்கங்க, ப்ராப்பராக லிட்டிகேஷன் போகாமல் நம்ம பார்த்துக்கணும். That's very, very important. So crite and cobra, very, very important. They may present with a dead patient. So very carefully, give ASV as quickly as possible. If necessary, SOS, ventilator support. Patient definite, they will come out very well. Role of calcium gluconate in crite bite. Actually, calcium gluconate previously வந்து crite bite and cobra biteல அந்த actually receptor level act receptor level, so neurological manifestation will come down அப்படின்னு முன்னாடி சொல்லிட்டு இருந்தாங்க. Nowadays various schools of that, it is more harm than good effect. It's not at all indicated as of now, at present. So it's harmful than better effect. Any
Crite
points?
is a presynaptic receptor, so it will not work for your acetylcholinesterase receptors. Yes, sir. Yes, sir. So initially they advised to go for calcium gluconate to increase the receptor opening, but a lot of studies have been shown that using a calcium gluconate is producing more harm rather than beneficial. So there is no robust evidence to support calcium gluconate in the crite bite. So don't ever practice, because if the patient die without other cause also, they are now saying that calcium gluconate producing sudden cardiac arrest because of stony heart. Okay. So on thrombophlebitis, it has been highly documented, produces severe sepsis and then patient dies. So again, calcium gluconate has to be used very cautiously.
Yeah, next slide. Complications of snake bite. So complication, immediate complication, delayed complication. So commonly you will lose the patient because of spreading cellulitis, improper management of spreading cellulitis, and inadequate ASV, an acute kidney injury, sepsis, local sepsis, septic shock syndrome, multi-organ failure. These three things. Sepsis stage le pannamna 100% you can recover. Severe septic shock syndrome, there is a 20% mortality. Multi-organ failure, 50% mortality. But fantastic center, you can also prevent. So all these things very important. So all this complication, if you, because of the patient negligence as well as physician inertia. So properly hit hard, hit fast rule is very, very important in the management of snake bite.
So this is a new tool, NGAL. Okay, it is a biomarker. Now it has been widely promoted. So we are using in our institute. This is NGAL, that is a neutrophil gelatinase associated lipocarpine. So this is an early biomarker before the creatine rise. So okay, the creatine will take at least 48 to 72 hours to rise. This we can identify within 2 hours. Okay, with this cutoff of anything more than 300 says that the patient is going to develop acute kidney injury. So we can prognosticate, we can reduce the volume overload, other nephrotoxic activities, and we can able to salvage. If it is more than 600 or 650, then it means that the patient definitely needs a renal replacement therapy. So early we can prognosticate to the patient. In a private hospital, it is very difficult. On the third day or fourth day, we used to say patient is good, nalla irukanga. Then third day, patient urine is reducing, we have to do dialysis. They will have a very in-confidence face on us. So when we start telling this in early itself, in the patient, in the report vandirukku, so kidney பாதிப்பு இருக்கு, dialysis தேவைப்படும். So what they will do is, they want to go for a next opinion, they will go to a different hospital, where they will say that the doctor will do like that only. It is not that, we will treat without any renal replacement therapy. This patient will go there, wait for 2 days, then they will have a decrease in urine output, creatine will rise, then this fellow will tell you have to go for dialysis, then they will come back to you. So they will have more confidence on you. So this test plays very important role. You can have it very cheap only. So it is very useful in the emergency room to prognosticate.
Yeah, like procalcitonin infection irka illaya sepsis paakra mari. So NGAL is a 600 rupees only. Very, very important. Creatine elevate agadhukku munadi it will. But in my clinical practice actually in the periphery, the important thing immediately ultrasound echo, ECG, then PTINR, shift the patient to ICU if you are suspecting snake bite, and urine output chart. You put the catheter every half hour, routine hourly 100 ml. Every half an hour 50 ml should come immediate. If it is not there for the next 2 to 3 hours, early acute kidney injury is there, so immediately triple R has to be instituted. Early renal replacement therapy, fluid challenge or continuous diuretic therapy or dialysis, yearly hemodialysis. These three things you have to start early. So acute kidney injury once sets in, no volume overload. Early phase, fluid replacement, fluid challenge. After that, it's a diuretic therapy. After that, you have to stop. Acute kidney injury sets in 80 and sets in immediately. Diuretic therapy as well as early HD, it's very important. So ultrasound, routinely in my clinical practice, all snake bed, ultrasound, echo, ECG and blood investigation, sift the patient simultaneously. Like heart attack and brain attack. எப்படி நீங்கள் த்ராம்பலைஸ் பண்ணுறீங்க ஹார்ட் அட்டாக்கு, தட்ஸ் 90 minutes டோர் டு பலூன் டைம் மாதிரி, தென் பிரெயின் அட்டாக்குக்கு வித்தின் 1 hourல சிடி இமீடியட்டாக சுட் பண்ணி ஹிஸ்ட்ரி இருந்தாலே போதும், சிடி நெகட்டிவ் இருந்தாலும் யூ ஆர் த்ராம்பலைசிங் அன்லெஸ் இட்ஸ் கான்ட்ராண்டிகேட்டட் இந்த பிரெயின் ஸ்ட்ரோக். ஸோ சேம் திங் ஆக்சுவலி ஸ்னேக் பைட் அல்ட்ராசவுண்ட் டெஃபினட்டாக வந்துட்டு 1 day ஓல்டுலாம் டெஃபினட்டாக இன்க்ரீஸ் கார்டிக்கல் எக்கோ, நிறைய டைம் 1 கிரியாட்டின் இருக்கும், 0.8 is normal, less than 0.8. So ultrasound yearly you can able to pick up mild increase in cortical echo. That's very important. Urine output chart. These two will comes yearly. Even either renduku munnadi NGAL. That's very important. So you can predict. So yearly triple R தேவை இல்லைங்கிறது வந்து very cautiously you have to do. Otherwise ஒன்றும் இல்லைன்னு சொல்லிட்டு நீங்கள் வரல 4 லிட்டர் 2 லிட்டர் fluid போட்டிங்கன்னா volume overload also can kill the patient. Many patients, they are dying due to the acute kidney injury. Many patients, they are dying due to the severe septic shock syndrome or multi-organ failure. That's very, very important message we want to pass it on. Okay.
The role of ultrasound, two things has to be seen in the snake bite. As a point of care, what we need to do is, we need to check for the renal Doppler rate. Altered in the renal Doppler rate, it indicates that the patient is going for acute kidney injury. That is the first thing. Second thing, in the bite site, we can look for it, whether the patient is more developed, any necrotizing fasciitis, or the patient is going for any compartment syndrome. There is no compartment syndrome in the snake bite, but I will come to it. This ultrasound, two things has to be monitored. Clear? Next.
So, another 10 questions are there. Quickly we'll rush it within 20 minutes. Compartment syndrome, does it really exist? டெஃபினெட்லி கம்பார்ட்மெண்ட் சிண்ட்ரோம், அதாவது கார் இடிக்குதான்னு சொல்லி இடிச்சதுக்கப்புறம் இடிச்சிருச்சுன்னு சொல்லக்கூடாது. ஸோ கம்பார்ட்மெண்டல் சிண்ட்ரோம் வந்து ஆக்சுவலி ஸ்னேக் பைட்டில் இருக்கா இல்லையா அப்படின்னு கேட்டால் இட்ஸ் நாட் அட் ஆல் தேர். பிகாஸ் இன் ஸ்னேக் பைட் லிம்ஃபேட்டிக் ட்ரைனேஜ் தான். ஸோ எடிமா ஸ்ப்ரெட்டிங் செல்லுலைட்டிஸ் வில் பி தேர். ஸோ லிம்பெடிமா வில் பி தேர். ஸோ இயர்லி ஸ்மால் cellulitis, lymph node enlargement, snake bite. So early small cellulitis, you can treat them with antibiotic, all the thing. If not settled down, you do the multiple lymphatic drainage. We'll come to that later. So compartmental syndrome, is it there or not? It's not there. Previously when we are doing the multiple plastic surgeon உடனே compartment syndrome வந்துச்சு, உடனே multiple incision அப்படின்னு போட்டிங்கன்னா many patients secondary lymphatic edema. Previously 10 years backலாம், last 5 years we are practicing, we are published in the international journal also along with the Senthil. Lymphatic drain, multiple lymphatic drainage, the yearly, even dense spreading cellulitis also, we are not doing the that's a fasciotomy. We are not at all doing since last 5 years. We are published in the international journal also.
20 years before, the compartment syndrome is a nightmare for the physician. Okay, we have to call the surgeon or orthopedician to come and open all 3 compartments. Okay, they will tell that in the night I will not able to open. You check for the pressure. If the compartmental pressure is more than 50, then we can come. These kind of things. It is very difficult. We don't have that kind of kit. Okay, but if you see the literature, the rattlesnake from USA or the tiger snakes from Australia, they'll produce a severe compartment syndrome. There, the venom transport pathology is entirely different. There, it will not be travel over the lymphatics. It is traveling through the vein. Okay, so it will be absorbed in the vein and then it will transfer. So it produces severe muscle swelling. If you see any trauma patient or the patient going for any rhabdomyolysis, crush injury syndrome, there they will have a all piece, pain, passive movement, loss of pulse, pallor, paresthesia. This all the loss of pulse is a last sign. But here we did a patient MRI. We did a MRI in the 24 patients in a control group, another one 24 in the snake venomation. We saw there is no fascia at all because this transfer over the lymphatic system and this will erode the fascia, so the muscle will swell. So you will see the swelling, but if you put the needle, the pressure will not be there because there is no compartment. All the fascia will be eroded by the venom. So there is no compartmental pressure. So if you put as compartment syndrome, your insurance company will not give you, we have to show the proof. So it is always says that there is a swelling. To reduce that, we can do a lymphatic drainage. That is much more safer and helps really the patient's outcome. Next.
Next slide. Role of lymphatic drainage. Since 5 years I am doing even a spreading cellulitis up to the abdominal, anti-abdominal wall and upper limb up to the chest wall, multiple lymphatic drainage. With the help of 15 size blade, surgical blade, with a 45-degree angle, multiple puncturing in the line. If you do very carefully, before doing lymphatic drainage, 20 WBCT or PTINR should be normal. You should correct the PTINR as quickly as possible within, in our hospital, maximum 12 hours. 12 to 24 hours. After that, I will do the lymphatic drainage. Even a small cellulitis, gross cellulitis or spreading cellulitis, multiple lymphatic drainage alone will prevent the acute kidney injury, septic shock syndrome, multi-organ failure. So, north narra mari 45 degree la multiple puncture. நீ ஓவர் enthusiasm ரொம்ப டீப்பாக போனீங்கன்னா மல்டிபிள் artery puncture or a vein puncture will be there. So very cautiously in the 45 degree angle, multiple puncture very cautiously you have to do. At a time, many time வந்து multiple over enthusiastic எல்லாம் பண்ணீங்கன்னா nowadays very important thing வந்து even diabetic food பெரிய gangrene எல்லாம் இருந்துச்சுன்னா ஃபர்ஸ்ட் நாளே பண்ணீங்கன்னா எல்லாமே it will suck out all the toxin will enter into the vein, it will enter into the system, suddenly septic shock syndrome, multi-organ failure will set in. So nowadays we are practicing like urolithiasis இருக்கு, கல்லை உடைச்சவனே உடனே septic shock போய் வென்டிலேட்டர் போடுற மாதிரி இருக்கும். அதே சேம் திங் வந்து டயபெட்டிக் ஃபுட் அல்சர் கேங்க்ரீனில் டோன்ட் டூ த டெப்ரிமெண்ட் அட் அ டைம், சேம் டைம். ஒன்லி கல்ச்சர் மட்டும் எடுத்துகிட்டு அடிக்யூட் ஆன்டிபயோட்டிக் கவரேஜ், அடிக்யூட் ஆன்டிபயோட்டிக் இந்த பிளட் வந்ததுக்கு அப்புறம் தான் ஸ்லோலி டூ த டெப்ரிமெண்ட். ஏர்லி நல்லா சூப்பராக பண்ணிட்டோம் அப்படின்னா பேஷண்ட் சர்ஜரி சக்ஸஸ்ஃபுல்லாக பண்ணியாச்சு, ஆனால் பேஷண்ட் டெட் அந்த மாதிரி ஆகிடக்கூடாது. ஸோ அதே மாதிரி மல்டிபிள் லிம்ஃபேட்டிக் ட்ரைனேஜ் டோன்ட் டூ த, இப்போ கிராஸ் செல்லுலைட்டிஸ் ஸ்ப்ரெட்டிங் செல்லுலைட்டிஸ்னால் டோன்ட் அட் அ டைம் ஃபுல்லாக பண்ணாதீங்க, பாதியாக பண்ணுங்கள். That is the message I want to pass on. And very important thing, adequate antibiotic coverage இருக்கணும், coagulopathy completely correct ஆயிருக்கணும், then only you have to do, cautiously you do. If the multiple puncture பண்ணிட்டு நிறைய ப்ளீடிங் ஆனவுடனே அப்படியே விட்டுட்டு வந்துடக்கூடாது. அடுத்து 6 ஹவர்ஸில் பார்த்தா நிறைய ப்ளீடிங் ஆகி இன்றைக்கி 12 கிராம் இருக்கும், நெக்ஸ்ட்டு ஒரு 4 ஹவர்ஸில் 4 சடனாக கொலாப்ஸ் ஆவாங்க. So very important, daily twice a day dressing, sterile dressing also, it's very important after doing multiple lymphatic drainage. This is a message I want to pass on. You can add Sendil.
When I put this paper in the international forum, it was criticized. Okay, lot of snake bite specialists, they didn't accept this lymphatic drainage. Even when I put this paper to pass into WHO, I'm in a WHO poison guideline committee. When I proposed this, everybody was start criticizing it. They says that there is no role for fasciotomy. You should not confuse fasciotomy with the lymphatic drainage. Lymphatic drainage is entirely different, fasciotomy is entirely different. So it was very tough to convince them. Even when we tried to publish this, it was rejected in 5 major journals. Then we put it in a different way, put it in an animal study, we showed, and then they started accepting it. Now the WHO is considering that lymphatic drainage is sufficient, but not more than 2 or 3 nicks it is sufficient. On the dependent area you can put, no need to put a multiple, because they can go for a toxic shock syndrome. So just a small, not more than 2 to 3 centimeter, it should be very superficial. We are targeting only the lymphatic drainage and not that. You can see when you put it in a dry dressing, you can see yellow color fluid will be there, it is a toxin. So until if you put an underpad and put it in the patient will start oozing. This is a yellow color fluid. So we have taken this yellow fluid and sent for the analyze, and basic microbiological and molecular level analyze showed lot of macrophages and lot of endotoxins were being identified there in that molecular level. So then it will become, color will be changed, and once it became colorless, it means that the entire circulating venom is removed. So you can safely suture them and put them on a grip bandage, they will settle very well. So the lymphatic drainage, if you practice only after correction of coagulopathy with an antibiotic cover. It is not a fasciotomy. Fasciotomy is no more indicated in the snake bite. Clear? This is entirely different.
We had a experience in Kanyakumari Medical College. So patient had a bite in the dorsum of the hand. So subsequently pulse is absent and the patient is going for impending gangrene of the fingers. In that situation, what will you do? The
Sir,
lymphatic drainage
that kind
will
of, no sir, even a small lymphatic drainage will definitely help. There in the finger is a very more potent, okay. If the bite is over the hand, it is not going to cause much harm. But in a finger, it contains lot of vascularity is very high, more amount of venom will be circulating into the body and produces severe thrombosis. If you do a imaging study, you can see major arterial thrombosis will be there. Then only they will go for a thing. We have recently published 7 cases of thrombosis from the hand going for entire gangrene. Then immediate opening and then we do a revascularization, we are able to save the limb.
Not only tenosynovitis is very common, thrombosis is also common, gangrene also. So immediately you have to, the thrombosis and gangrene, you have to do the debridement, remove amputation of the particular finger. And tenosynovitis is very, very common, tendon. It will spread to the tendon. You have to remove the tendon to get a better rehabilitation.
Look for the Kennel sign. Okay, this Kennel sign, if the patient is positive with the Kennel sign, it means that the tenosynovitis is started, give a good removal so that the toxin will be getting out. Here you cannot put anti-inflammatory, this patient will go for renal failure.
So limited lymphatic drainage. So initially yellow color fluid, slowly it will color change will be there. So lymphatic drainage is the rule of the day. Actually no need for the multiple, that's a for the like compartment syndrome. Fasciotomy should not be superficial deep fasciotomy. Nowadays no role at all. Only lymphatic drainage is more than enough. Cardiac complication. Many
How common you see cardiac complications? How common you see? Very common in cobra bite. If you see a cobra bite, always put the patient on a cardiac monitor. Continuous cardiac monitor for next 48 to 72 hours is mandatory. Most of the time they will go for a short arrhythmias, SVTs, ectopics. We have seen lot, especially in a cobra bite. Now the cobra bite incidence is reducing, but still if you get a cobra bite, always remember that we need to check for the cardiac events.
2 months back, a younger, around 40 years old male presented the same cobra bite. He was intubated and recovered, but suddenly within 24 hours he developed extensive anterior myocardial infarction. Because of that myocardial infarction, we lost the patient. So he developed a cardiogenic shock, everything. But he was on ventilator, he was recovered, he extubated, but subsequently he developed severe chest pain. BP pulse not recordable, subsequently he succumbed to death.
Because of thrombus in the area.
Kuhn's syndromes. Kuhn's syndrome like
vasospasm only.
Yes, sir.
Thrombosis
will be there. So Kuhn's grade 3, it is grade 2 is thrombosis, grade 3 stunt thrombosis.
Crohn's syndrome. Many times ASV induced Crohn's syndrome and cobra bite suddenly and the fearly sudden acute coronary syndrome they may develop thrombosis. There are various etiologies. But
sometimes they again go for Takotsubo cardiac syndromes.
Because of
stress.
That's a catechol means severe sympathetic overactivity. Takotsubo syndrome can develop. You can lose the patient. So capillary leak syndrome and management. Capillary leak syndrome. Capillary leakage syndrome na dengue da namak nyavam irukum. Whether it will occur in snake bite. Or 2 patients I came across actually. அதாவது என்ன 30 வயல் ஏஎஸ்வி ஹையர் ஆன்டிபயோட்டிக் ஏர்லி டயாலிசிஸ் எல்லாம் கம்பார்ட்மெண்ட்ஸ் அண்ட் மல்டிபிள் லிம்ஃபேட்டிக் எவ்ரிதிங் பண்ணியாச்சு. பட் 24 ஹவர்ஸ்லேயே கேப்லரி சிண்ட்ரோம், கை கால் முகம் எல்லாமே பஃபியாக வீங்கி இருக்கு. கேப்லரி சிண்ட்ரோம் வந்தது கேங்க்ரீன்லாம் புவர் ப்ரோக்னோசிஸ். ஸோ ஸ்னேக் பைட் ஆல்சோ எஸ்பெஷலி ரசல் வைப்பர் சம் ஆஃப் த பேஷண்ட் ஹீமோலைட்டிக் யூரிமிக் சிண்ட்ரோம் நிறைய we are some of the patient. In spite of ஒரு காலேஜ் கேர்ள் ஆக்சுவலி 3rd year ஸ்டூடெண்ட்டு வந்து நைட்டில் மழை பெஞ்சிருக்கு நடந்து வரும்பொழுது பெரிய ரசல் வைப்பர் போட்டு அங்கே ஜிஹெச்லேயும் 20 வயல்ஸ் போட்டாங்க. நானும் போட்டு எல்லா ஆன்டிபயோட்டிக் எல்லாம் கொடுத்து மல்டி ஆர்கன் ஃபெயிலியர். ஃபைனலி ஆன் 6th day patient expired because early capillary leakage patient developed actually. Capillary leakage is one of the poor prognostic indicator, and he will share Senthil will share his experience.
Capillary leak syndrome will not occur in all snake bite. Okay, only particular people will be there. For per year we are treating almost 250 to 300 cases of snake bite in our hospital, of which 10 patients will develop capillary leak syndrome. So this is because whatever the neutralization with the ASV we are doing, everything is not being neutralized. Snake venom contain lot of other protein complexes like MVP. Okay, metalloproteinase is the culprit causing this kind of thing. Sir's friend Dr. Stephen is now inventing a new oral anti-snake venom where it is neutralizing with the metabolase protein. So that reduces the capillary incidence of capillary syndrome. And again, sir is the first person to document bilateral parotid swelling is a grave prognostic indicator. But that is the first sign in developing a capillary leak syndrome. The capillary leak syndrome adequately, suddenly the patient will rise. Recently we had a patient, a Muslim lady, came, we have a bed with all the body weight will be measured. So it was just only 65 kg at the time of admission. Within 4.5 hours, she became 82. Okay, at end of 6 hours, she became 100 and very difficult in breathing. Then we intubated, then we took the patient immediately for the hemodialysis, and volume removal was being able to achieve it. Okay, with continuous albumin infusion. The pathophysiology behind this capillary is because of this causing a vascular permeability will be damaged. How much amount of albumin you pour in that, it will again start leaking it. We have to support the system for 48 to 72 hours. Then they will slowly improve. Otherwise, they will die. Okay?
So important management of capillary leak syndrome, Senthil?
Sir, early dialysis, even if the patient you suspect plasmapheresis can be taken, but early dialysis is very, very important, and Montelukast is helping out. Now in the animal study it is proven that early Montelukast, when you are giving Montelukast supplemented with steroids, then it is helping out to reduce the vascular permeability. What we are doing in allergic rhinitis, the permeability here it's opening out, continuous congestion is there, that is being relieved with the Montelukast. Same mast cell stabilizers are being employed here, and it has been used in the animal studies, and we have started using in all our snake bites routinely with the Montelukast, and we are seeing the reduced incidence is coming out.
And albumin.
Albumin we don't do regular albumin, sir. Unless it is mandatory, then we will do. Okay. The early sign is you do a urine albumin. Urine albumin will be, initially it will be negative, trace, then 1+, 2+, then the ascending weight will be there. It gives a clue that the patient is going for capillary leak syndrome.
Okay. So albumin estimation like diabetic patient, microalbuminuria like that, A1, A2, A3, you have to serially, you have to look into that. A1, A2, A3 albumin also you have to look in. So already when you can predict more prone to develop capillary leak syndrome, mortality is higher, you can predict the patient. So pregnancy and snake bite.
How many of you have treated pregnancy and snake bite? How have seen? Initially it was very low. For past 15 years I have seen only 5 to 6 patients. Now recent 5 years I am seeing lot patients, because the pregnancy they are going for pregnancy wed photography. They want to go to the remote area and they are taking lot of pictures. They are coming with snake bite. Okay, I am not joking it. With the pregnancy wed photography, I have seen more than 20 cases of pregnant lady getting a snake bite, exposed to snake bite. Okay, they are coming out with this. So you treat it just like other patient, you treat it, they will improve very well. Okay, there is no separate that. The venom is not crossing the placenta and the fetus is not getting it. Only thing, mother should not be hypoxic. If the mother is, what is good for mother is good for the fetus. Just treat as what you do for the regular patient.
Pregnant lady, குழந்தை அப்படினு பாவம் புண்ணியம் பார்த்தலாம் கடிக்காது. அதே same type of venom will be there. So same management like all adult patient. Okay, previous slide.
Forced alkaline diuresis.
Yeah, next slide.
No role.
No role
in snake bite. Next.
Management of pit viper bite. Pit viper bite, Rajasthan, Kerala, it's very common. No ASV, there is no role, only plasma paresis. Early plasma paresis. If you suspect pit viper and you can able to identify, definitely Pit viper, definitely plasma paresis is the only
Sir,
identification.
pardon sir?
We are treating with all ASV and there is no improvement in
Yes, sir. Sir, it is not that only in Rajasthan and Kerala. Now we are seeing in Tamil Nadu, especially in the Western Ghat, we are seeing hump nose pit viper. In Kalrain Hill region, we are seeing green pit viper. Both snakes, they are not effective to ASV. After 30 vials also, still the coagulation will be there. Coagulopathy will be there and the patient will start bleeding. Then we can start them on FFB or go for early plasmapheresis. Okay.
FFB and plasma paresis, these are the two
Next.
things. Yeah, next. Management of sea snake bite. Sea snake bite, 4 species, big 4 species ASV may not be helpful, only 10% it may effective. Because sea snake bite it not be helpful. Here also FFP and plasma paresis.
Here in sea snake, they will go for rhabdomyolysis. Early dialysis is indicated and cross reactivity is there within our common big 4 and sea snake. So there is 10 to 15% improvement is there with the ASV. So don't deny ASV just saying that it is a sea snake. They will slowly they will improve it. Okay.
So previously sea snake bite na 100 vials அப்படினாங்க.
Next.
Nowadays it's not there, no, Sandil.
Yes sir. No 100
Maximum
vials.
30 vials. So 10% benefit will be there. Next slide.
Over sir.
Okay.
So now it is open. Any questions, anything you want to ask, we can.
Anything, everything about snake bite, you can ask quickly. If you ask quickly,
Yes.
we will answer many questions. And we will come to a conclusion. இப்போ மைக் கொடுமா.
Sir, beyond 30 vials we can give or not, sir?
No,
Because we-
only 30 vials maximum.
Okay, sir. Is there any species difference for any ASV injection?
Yeah, we have discussed pit viper. hump
Geographically,
nose,
it is different. Geographically, if the patient has been bitten in Kerala and we are treating with the batch which has been received from the central manufacturing unit, it is not responding. Okay, the forest snake is again different. Farm snake is again different. Russell viper, we have to give maximum 30. Saw-scaled viper, 10 to 15 vials is sufficient. In cobra and kite, we have to give 20 vials.
Statum. Yeah, questions, quick questions.
Sir, after 30 vials of ASV for coagulopathy, we have to repeat APTT, PT-INR after 6 hours, and then after that we have to give FFP or we'll wait.
We have to, if it is
Every 6
PTF
hours you have to see, and you see that there is increasing in the prolonging in the INR, or the patient is having a bleeding manifestation, then we have to give. Don't just treat the numbers. If the patient is symptomatically better and mild prolongation is there, we have to wait and watch. Okay?
After 30 vials, FFP 4 units, then again 6th hourly you do the CT or PT-INR. If it is elevated, maximum 2 doses of 4 packets of FFP. After that, clinically better, no need to repeat. Maximum 4 units of FFP, repeat if necessary again. That's a maximum. Maximum ASV is 30 vials. The viper and the all viper, Russell viper, and saw-scale viper, he has pointed out 10 to 15 maximum. And cobra and kite, maximum 20, statum.
Sir, when to suspect pit viper? What are the signs?
First is location, ma'am, area. Which area the patient is there. If the patient is there in the endemic area like Satyamangalam forest or Kerala, in the border of Kanyakumari, Sengote area, we are seeing lot of snake bites. That kind of area, yes, we can think of pit viper as one of your DD. And after giving enough 30 vials, still the patient is not improved in the coagulopathy, then you can think of pit viper.
While monitoring, if the INR comes to no coagulation and the patient is clinically stable, do you wait or you proceed with after 30 ASV vials, patient shows INR of no coagulation. Sometimes it has happened in our hospital, sir. Do you wait or do you give FFP? Still it shows no coagulation.
Okay, give FFP.
Patient is stable, so
Then we can wait and watch. We can wait and watch, but keep ready of your ASV, everything. If there is gum bleed, that is the first sign. Immediately you can start giving ASV.
After that events over, gum bleeding is there, give FFP 4 units. And
Without-
every 6th hourly.
Without bleeding, no FFP.
Yeah.
Ma'am, I will tell you, this is a study which has been done long back In 1960s, they did a study, and they did lot of timing was being given. From the 5 minutes to 1 hour it was given. And based on the consensus at the time, the toxinologists, they told that we can give maximum of 20 minutes just to reduce the protein bound. Now we are not advising. Even the WHO is saying that 20 minutes whole blood time is for the remote resource limited
Places.
area. Otherwise, we go for PT APDT. And
PT,
other important thing
INR
is
or CT.
other
Clotting
important thing in PT APDT. Now we are in the point of era test. Point of POCT is there. Don't do POCT. Okay. So I had a patient was a cardiac surgeon's father, had a bite and then had a gum bleed. So they did a PT APDT in their home itself, and they came as negative. So they were keeping the patient, and after 3 times of test also, still it was normal, but the patient started bleeding. They came to our hospital. We did a lab, it was prolonged. Then we cross-checked with the machine. The machine is designed only to give the PT-INR value for only 4. If it is more than 4, it will automatically come to default as normal. So don't rely on your point of care test. Okay.
Point of care is not important. Clinical manifestation is very important. Gum bleeding is very important. Yeah, quickly. Still running short of time.
In peripheral government setups, sometimes we'll have ASV from 2 different manufacturers. So what to do in that situation?
This kind happens even in the private hospitals, sir. You have to check which contain more and what is the symptom. If the patient needs 10 vials, only you are having a 10 with that brand, you go ahead. Or if you think that the patient needs a little more, and if you see that little more, you can go. But unfortunately, you have 10 in this and 10 in this, then we can give it. It is not going to have problem. But the cross reaction between these 2 brands will happen. We have witnessed.
But no other go. You have to give. If you are having a same brand, repeat the same. If you're not having, you can give mix with, but you have to anticipate any reactions and treat accordingly. Yeah, quickly. No, time frame. Actually,
It is not that. Even the delayed manifestation.
also there.
Up to 96 hours.
90 up to 96 hours. Even third day, if the patient is coming, CT is elevated, PTINR is elevated, immediately give. Till 96 hours, definitely. Mostly the first 12 hours, first 6 hours. So usually up to 96 hours. Even 4th day they are coming, CT is elevated, PTINR is elevated, immediately give, repeat the same. It's a costly. Huh?
Pit vapor, it is not so dominant. And the clinical symptom produced by pit vapor is not also well documented. Only we are doing a lot of research on going on. Soon we will come with it.
Yeah.
Sir, in my patient, even after 25 vials of FFP, patient whole blood clotting time was not FFP, sir. After ASV, ASV 30 vials was given, sir. Even after. Yes, sir.
Capillary
3
leak
things
syndrome.
you have to think, whether it is really a pit vapor or a green pit vapor, or whether the lab parameters are correct, or the patient is having any symptoms. No, leave about coagulopathy. Renal failure, it is different. Renal failure, bleeding, any bleeding manifestation, then no need to treat. The hemoglobin drop is there, occult stool blood test has to be done. You have to see if there is any diffuse use is there. Then we can supplement them with vitamin K. Then it is not exactly a Russell Viper or anything. If they are improving with the flux, then it means that the patient is having a pit viper or any cross reactivity is there. We are now seeing, it looks like a Russell Viper, but the venom behaves like a pit viper. Okay.
In
Probably it may be a pit viper.
Capillary leak syndrome also may not, CT may be elevated, no, Sandil? Capillary leak syndrome also.
So many of people are working in a primary center and GH, they are not doing, even if it is a witnessed snake bite, poisonous, initial treatment is most of the time it was delayed or denied. They just infuse 1 vial of ASV and send back to the tertiary care center. That is not ideal. Never do like this. Most of the people probably working in a GH and primary health center. If you don't have enough facility, early referral to the tertiary care center. Don't waste time using single vial of AS. Most of the things it was happened in our tertiary care center in Kanyakumari Medical College.
They believe something is better than
Yeah.
Sir, conclusion remarks, some comments.
It was an excellent presentation by both of you. Nalla research எல்லாம் பண்ணி சொல்லியிருக்கீங்க. One more point I want to add is that lactating mothers, they can breastfeeding கொடுக்கலாமா வேண்டாமா?
They can give, sir.
Yeah.
They can give.
That they should know about it.
So conclusion remark from Dr. Palaniappan, actually don't hit hard, hit fast rule is very, very important. Confident-ஆ ட்ரீட் பண்ணுங்க. அண்ட் மெயினாக வந்து ரியாக்ஷனுக்கு ரெடியாக அட்ரினலின் ரெடியாக வச்சுட்டு ட்ரீட் பண்ணுங்கள். ஏஸ் நான் ஃபஸ்ட் எய்ட் பண்ணிவிட்டு போகிறேன்னு சொல்லாதீங்க. தென் டர்னிக்யூ ரொம்ப இம்பார்ட்டன்ட். டோன்ட் அட்வைஸ் டர்னிக்யூ. இஃப் அட் ஆல் அட்வைஸ்னால் ப்ராப்பர் டெக்னிக்ஸ் வெரி இம்பார்ட்டன்ட். ஏஎஸ்வி வெரி கிளியர். 10 vial sausage wiper, Russell wiper, 25 to 30 maximum, and Cobra and Crite maximum 20 statum. Usually the now protocol is 45 minutes 10 vials, then 15 minutes wait, again repeat CT or APDT or 20 WBCT, depends upon your availability, what you trust on that. Then 10 vials, after that 10 vials, maximum 30. 30 மேலே வேணவே வேணாம். Then still CT or APDT is elevated, give 4 units of FFP, still not control, again you repeat, still not control, depends upon the clinical features you decide. மெயினாக கம் ப்ளீடிங் இஸ் வெரி இம்பார்ட்டன்ட். அனஃபிலாக்டிக் ரியாக்ஷன், காதெல்லாம் சூடாகுது, மூச்சு விட கஷ்டமாக இருக்குன்னா இம்மீடியட்டாக போட்டுருங்க. பேண்ட் இருந்தாலும் சாரி இருந்தாலும் இம்மீடியட்டாக அட்ரினலின் போட்டுருங்க, ஆஃப் சிசி. தென் தட் வில் சேவ் த பேஷண்ட், மார்ட்டாலிட்டி வராது. ஸோ செகண்ட் டே இந்த கேப்லரி லீக் சிண்ட்ரோம் வெரி இம்பார்ட்டன்ட். அண்ட் ஹம்ப் நோட் பிட் வைப்பர், இது வந்து ஏஎஸ் வில் நாட் பி ஹெல்ப்ஃபுல். ஸோ இயர்லி பிளாஸ்மா பாரிசிஸ் ஆர் டயாலிசிஸ், early intervention plasma paresis is very, very important. ASV will not be work out at all. Main on the spreading cellulitis, lymphatic drainage, few lymphatic drainage, multiple lymphatic drainage, that will save the patient. So yellow color it's actually toxins will be released. So daily twice a day dressing is very important. Consumption correct பண்ணதுக்கப்புறம் you have to give with adequate antibiotic coverage is very, very important. Acute kidney injury, early detection NGAL or ultrasound the Doppler as well as over the site. You can do the ultrasound, and early you can predict acute kidney injury early also. And in clinical practice as a physician, complete physician, half-hourly urine output chart. அப்போ பார்த்துட்டு ப்ராப்பராக யூ ஹேவ் டு சி. ஒன்ஸ் அக்யூட் கிட்னி செட்ஸ் இன் அப்படின்னா ஸ்டாப் ஃப்ளூயிட், வால்யூம் ஓவர்லட், இட் வில் கில் த பேஷண்ட். ஸோ அடிக்யூட் ஆன்டிபயோட்டிக் கவரேஜ் அண்ட் இயர்லி லிம்ஃபாட்டிக் ட்ரைனேஜ் அன்லெஸ் இட்ஸ் கான்ட்ராண்டிகேட்டட், and early RRR management, and cardiotoxicity, you have to watchful expectancy, properly you have to manage. And the compartment syndrome, multiple fasciotomy, superficial fasciotomy, it's gone. So proper management, adequate ASV, and delayed reaction also you have to keep it in mind. Delayed when a protein bound, so olein and seed mari, even 96 hours, up to 96 hours ASV is indicated. So these are all the important carry-on message we want to pass it on. Higher antibiotics is very important. Associated comorbidities also simultaneously you have to manage. Many times volume overload will kill the patient. Early dialysis is very, very important. Early dialysis பண்ணீங்கன்னா definitely recovery will be good. Some of the patient once AKA sets in, daily dialysis கரெக்டாக 2 weeks கழிச்சு தான் யூரினே வரும். So daily you have to do the dialysis. AKA definitely it will come out. And capillary leak syndrome, if you are suspecting, முன்னாடியே ப்ரிடிக்ட் பண்ணிடுங்க, மே பாப் ஆஃப் இன்ஸ்பைட் ஆஃப் லேக்ஸ் டுகெதர், ஸ்பெண்டிங் லேக்ஸ் டுகெதர். ஸோ ப்ராப்பர் இன்ஃபர்மேஷன், ப்ராப்பர் லிட்டிகேஷன் இல்லாமல் எல்லாம் ப்ராப்பர் இன்ஃபர்மேஷன் இஸ் வெரி, வெரி இம்பார்ட்டன்ட். டெய்லி அப்டேட்டிங் டு த அட்டண்டர்ஸ் இஸ் வெரி இம்பார்ட்டன்ட். யூ வில், we are living in the litigation era. These are all the important carry-home message I want to pass it on. Over to Dr. Sendil.
So today we had an extensive lecture. I think most of your doubts have been cleared. And I'm now heading the Asia Oceanic Association of Medical Toxicology. This is a 66 years old association. First time an Indian is taking over the charge. It has been dominated fully by Chinese. Thank you. dominated fully by the Chinese. So even in WHO, I am one of the panel member in WHO, they will not allow us to enter into that protocol committee. They will decide everything and they will come, they will send the protocol, just ask us to sign it for the majority. That was the scenario. Now we have changed it and slowly we are dominating slowly, and we have started a new group called as Research Society for Study of Snakebite in India. Almost everybody is seeing at least 5 to 10 cases of snakebite in a year or in your post-graduation. Please try to publish at least one paper on snakebite. Because what they, in international people, they think that Indians, they are seeing and they are not enough in documentation, or they are not enough, they are not confident in handling the cases which has been rightly performed in the international forum. Please, I just have a plea and request to you. Please submit at least one paper in any journal and try to put it into our website. It is Research Society for Study of Snakebite in India. I will just share the website. You can put it, and this will help in the international forum, putting our country in a little pride. Thank you.
Thank you very much.